Namaskar and good evening, everyone. I welcome you all for today's webinar on clinical updates in common cancer. With immense pleasure, I would like to invite our program convener, Dr. Sanjayan Mandal, who is consultant medical and hemato-oncologist at HCG Cancer Center, Kolkata, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Yeah, good evening, everybody, and basically, I welcome everyone. So I think um, gradually the faculty and other person will join. So I just first just want to have the details of the faculty who are actually today will be present with us. So our what there will be one panel discussion after my introduction and my panel short introduction and epidemiology on cancer. The panel discussion will be moderated by Dr. Vamsi Krishna from Hyderabad, AIG Institute. He is the director head and of the medical oncology and hematology, and his panelist will be Dr. Pradeep Kumar Mondal. He is the consultant medical oncologist in Manipal Hospital, Kolkata. And Shushant Paikre, Bhubaneswar. He is also consultant medical oncologist, HCG Panda Cancer, Katok. Dr. Kaustav Mojumdar, Kolkata. He is also medical oncologist from CNCA Newtown. After that, there will be lots of educational sessions that will be gradually from Dr. Satish Sharma. He will be presenting topic. I will tell and discuss one by one. He is the consultant medical oncologist in Bhagwan Mahavir Manipal Hospital, Ranchi. Gunjesh Kumar Singh. Uh, he is senior consultant medical oncology in Paras Hospital, Ranchi. And we have our special two oncopathologists also. Dr. Devmallo Banerjee, he is consultant and lead oncologist in RN Tagore Hospital, Kolkata, and Dr. Nirmal Banerjee, he is consultant histopathologist and oncopathologist in CK Birla Hospital, CMRI, and RN Tagore in Kolkata. We have Dr. Tomojit Chaudhary, he's medical oncologist, consultant in Apollo Multi-Speciality Hospital Clinic, Jamshedpur. And myself, I have already given my introductions. So this is our agenda, and I wish there will be a good interactive and educational session for the next around 3 hours. So
So, to begin with, sir, with your talk, epidemiology in breast cancer, I
yeah, can
invite you.
we just wait for 1 2 minutes? After that, we'll start.
Sure, sir.
Oh. So let's start my session to begin with.
Yes, sir.
So, good evening, everybody. Let's start our discussions. So, today, my sessions, I will give the introduction and followed by the sessions on epidemiology of cancer. So, first of all, I like to thank the organizer for this wonderful session they are organizing and get together all the doctors at one platform in this evening. I know all the medical oncologists who have joined, they must have been busy schedules. I also really grateful to them that they find the time out of their busy schedule and joined here. So to start, epidemiology in breast cancer. Next slide, please. So this is actually the 2020 the Glucagon data. The compared in female, the it corresponds to the number one breast cancer. It is constitutes around 24%. The maximum compared to the other cancers in female like colorectal, lung, uterine, cervix, thyroid, stomach. Next slide, please. So this is the at a glance statistics of incidence in the cancer risk populations compared to the males and females and both sexes. So if we consider the 5-year prevalence, it is more in case of the males and compared to the females. So top leading cancer ranked by cases, head and neck cancers, head and neck cancer, followed by lung, followed by esophagus. That is our most presentations in males, and females it is breast, cervix, uteri, and ovary. And overall, if we consider the both sexes, breast comes first, then head and neck, lip, oral cavity, and then cervix, uteri. And if we consider the risk developing cancer before the age of 75, so it is same in case of the both males and females, that is almost 10% in both cases. Next slide. So we are now focusing on the basically India. So epidemiological studies, they have actually shown increasing the global burden of the breast cancer, and it is expected to cross around 2 million by the year of 2030. So the incidence rate of India that has been increased by almost 50%. It is if we consider the old data in consider the 1965 and after 20 years in 1985. Now in 2016, there also was some increasing the incidence estimated was around 1 lakh 18,000 cases, and 98% of which are female, and prevalence was around 5 lakhs 26,000. And over the 26 years, the age standardized incidence rate in breast cancer in female increased by 39% from 1990 to 2016, and increased observed in every state in the country. So every state in the whole country in India, there actually shows increasing incidence and mortality rate in breast cancer. And at par in 2020 Globocon data, breast cancer accounted for 13% of all cancer and 10% of the all death. And it is cumulative risk is around 2.8. Next slide, please. So that we already shown the data that head and neck cancer are the leading in males. Next slide. And females, it is the breast cancer. Next slide. And if you consider the both sexes, as I have already discussed, that most are the breast followed by the head and neck, and followed by cervix in uteri. And percentage wise, breast is 13.6% leading, and followed by 10% in the head and neck, and followed by 9% in cervix uteri. Rest are the single digit and mostly 5%. Next slide. So this was the 2022 data, and if we consider the all the cancers, breast consider whether if we consider the new cases, the cumulative risk is 2.9%, and mortality are 1.6, and 5-year prevalence is 77 percent. Next slide. So, incidence-wise, country-specific data, we have different registry state-wise, like Mumbai Cancer Registry, Chennai Cancer Registry, or Nagpur Cancer Registry, like that. And method, they have used the weighted simple average of the most recent subnational rates. And mortality also country-specific data source, survival estimate method, that was also have special data centers where they have collected and calculated the mortality rate. Next slide. So if we consider the world incidence of the mortality rate in top 15 cancer, we can see the incidence is around 26% in breast cancer, being the top of all cancer. And in mortality rate is also higher in breast cancer, 13, followed by the cervix uteri. Next slide. So if we consider the incidence rate per sex, in female most is the 26% leading in the breast cancer, followed by cervical cancer, and in males the head and neck cancer bleeding is around 14%. Next slide. Next slide. So this is the global breast. The breast cancer is the most common diagnosed cancer among women, and 26% of all female cancers, and it is the second leading cause of mortality in women today after the lung cancer. And yearly around 18 million new cases has been found. Next slide. So this is the cancer occurrence wise global breast cancer epidemiology, where breast cancer constitute the 26%, and followed by the lung cancer and colorectal cancer, other cancer. This is the global epidemiology. Next slide. And if we consider the mortality wise, it is considers second most common after the lung cancer. It consists 26%, followed the 15% in breast cancer. Next slide. Signs and symptoms, we all know about this. Next slide. So, location of the breast cancer, as we know that upper outer quadrant are the most common, consist of the 50% of the most location of the breast cancer. Next slide. So these are the common risk factors, as we will know, all know. Next slide. So prognosis of the breast cancer, as we all know, that age is the number one, that is the bad prognosis in patients younger than 35 and older than 50. There is also BRCA status, that is the worst prognosis if it is positive cases. Although we have the targeted therapy in BRCA positive cases. Previous slide, please. So BRCA positive cases, and carcinoma breast is also most common in if it detected in the pregnancy, and during the use of the contraceptives is a bad prognosis. Also the size it matters. Lymph node involvement and distant metastasis also, it is an advanced stage of cancer and also denote the worsen prognosis. Also during the treatment we have the gradation of the tumor proliferation rate. Highest the proliferated worsen the prognosis. And also the treatment of the breast cancer, we all know that it depends on the most ER, PR and HER2 expression Ki-67. Next slide. So these are the breast cancer prevention and control. The WHO recommend the promote of breast cancer control with the context of comprehensive national cancer control program that are actually integrated into non-communicable disease and other related. So, comprehensive cancer control like prevention, early detection, early diagnosis, early treatment, rehabilitation, and palliative care. So, these are the parameters, both from the screening point of view, prevention of the breast cancer, early detection, and rehabilitation and palliative care also are the part of the important therapy when the patient especially comes in the advanced stage of cancer, multiple line has been exhausted. So these are the very important part of the treatment program also. Next slide. So this is just a nutshell in prevention. As you all know that as we have seen the data that increasing global burden is a there's a grim in all over the world, and it is also a headache for the all the states of the India. So it's action to take the lower chance of getting cancer. Prevention is the best method to reduce the new cases detected, and some risk factors can be avoided, like changing the lifestyle, eating habit, like a healthy diet, exercise, or reduction, avoiding the smoking, alcohol, avoiding taking the oral contraceptive or hormone replacement therapy, having children prior to 30 years, encouraging breastfeeding, and prophylactic tamoxifen in high risk patients that are also under trials. Next slide. So these are the screening methods. As we all know that cell breast examination and clinical breast examination every 3 yearly, mammography after 40 up to 75 years. Some school recommends high risk cases they should start screening from 25 years also. Next slide. So, women with increased breast cancer, those who have a strong family history, more relatives, either first degree or second degree, premenopausal breast cancer, family history of BRCA1 and 2 positivity, those who have the had a chest radiation at least 10 to 30 years ago, especially for some disease or Hodgkin lymphoma in childhood. Patient has a personal history of breast cancer of the other breast, or some precancerous like ductal carcinoma in situ atypical hyperplasia that may develop in future to be kept in observation. Next slide. Next slide. So early diagnosis, reducing the portion of the patient who are diagnosed at late stage. So there are three steps to detection, like awareness and accessing the care. There are many village people or non-urban population that are actually devoid of this screening program, and they actually comes in advanced stage of breast cancer. So awareness in access of this healthcare facility is very important. Step one. Step two is the clinical evaluation, diagnosis and staging. So proper diagnostic facility like mammography or ultrasound, MRI, CT scan, that should be basic requirement. Those who are actually non-urban populations, there is not facility for early diagnosis. So that is the step two. And step three, the access to the treatment. That is the most challenge for us in India, because we have seen many people are coming from far distant area, from the city or urban populations. They actually, number one, due to the lack of awareness, due to the delay in diagnosis, they actually have the advanced stage of cancers. And when we get this type of patients in our clinics, when they actually come to a setup where all facilities are available to treat the cancer, that time we may often found there is advanced stage of cancer. And sometimes personal neglect is also the reason. When there is a localized breast cancer, they often neglect, and after a couple of months they actually present with the very high burden or disease, or like metastatic disease. Then it is actually from curative our intent complete to the change to palliative intent. Next slide. Next slide. These are actually the basic parameters that will be told. And now management has already changed from standard chemotherapy, surgery, radiation therapy to the targeted therapy, immunotherapy, and antibody drug conjugate. These are new molecules are coming up to increase the survival of the advanced stage of cancer. Next slide. So, what are the problem facing the implementation? Mainly the lack of optimum facility in breast clinic, like proper place, personnel, lack of trained female radiologist or mammography technicians. All clinics are ideally in tier one or tier two cities. So, smaller cities or village populations, they actually lack improper coordination and communication between the health provider. That is the important. That's why there is a lack in diagnosis, and initial screening is also deficient, and incomplete referral system with poor feedback of the referred women, and improper role of media and public health awareness, and level of illiteracy is high among the female. That's why we often miss the chunk of population diagnosis in curative setting, like in early stage, where we can actually cure the patient. Next slide. So, thank you everybody for the patient hearing. So, to start our next session, there will be a good, interesting panel discussion. This is actually sponsored by Novartis. So, I would like to invite Dr. Vamsi Krishna. He is the director and head of medical oncology and hematology, AIG Hyderabad. And he would like to call his panelist, Dr. Vamsi. Please.
Yeah, hi. I'm here, Sayan. Just give me 1 minute. There is some challenge with my laptop. I'm not able to load the slides.
Oh,
So if you
sure.
just give me a minute, I'll just see if I
Yeah,
can
yeah.
log in.
No issue. No issue. No
Yeah,
issue.
just a second. I have logged in on my phone. So if you have the slides with you, I can
Sir,
present
can I
from
share?
that. Yes, you can share. Please go ahead and
Okay.
share.
Okay, sir. Okay, sir.
I'm really sorry for this. It was working perfectly fine till now. Suddenly it seems to have stopped. There's some challenge with
No,
the.
network issue is always there. Network
No,
issue is.
it's not network. It's some stupid thing to do with my. Where the challenges come. Anyways. All right. So I have my panelist, Dr. Kaustubh. I could see Dr. Susanta is there. Are all the panelists there? Dr. Kaustubh, I could see. Dr. Pradeep and Dr. Sushanta, have they joined?
I think they are yet to. I'm just
Okay.
telling the call. Just wait 1 2 minutes. Just wait.
All right. All right. Sanjay, should I just make it as a presentation rather than a panel?
I think they have already on board.
Yes, sir. Dr. Pradeep already
Pradeep,
joined.
and Dr. Kostab has joined.
All right, let's start off the
And
panel discussion then.
yeah,
Okay. So, good evening, everyone, and thank you, Dr. Sanchan, for giving this chance to speak on first line HR positive, HER2 negative advanced breast cancer. Obviously, we'll be focusing on the CDK4/6 inhibitors, and it is a sponsored session. Those slides have been provided from Novartis. Next slide, please. So, when we talk of HER2 negative and HR positive, the whole uh, paradigm of treatment has really undergone a huge change in the last few years. I mean, 6, 7 years back, this was hardly a topic we would discuss. The good old days of discussing whether we are going to be giving letrozole or tamoxifen, and today we are talking of survivals, we are talking of complexities like patient treatment goals, what are the responses to prior treatment. So the whole treatment has become rather complicated. Next slide. So presently, when you look at all the treatment guidelines, first line remains a CDK4/6 inhibitor plus endocrine therapy. Next line, next slide. And what we need to really look into is what are the results from the key trials. Again, these are names that have become very familiar to us. We talk of Mona Lisa, we talk of Monarch 3, we talk of Paloma 2, and we talk of Mona Lisa 2. And again, when you look at the hazard ratios, I think this is the probable headline slide, or as someone says, the money slide.
Not audible.
Hello, am I audible now?
Yes, sir. Thank you.
Sorry. So I was saying that this is probably the money slide for us, wherein if you notice the hazard ratio for ribociclib in the ML2 is around 0.76 with a positive statistical significance, whereas while Monarch 3 had a OS of around 0.8 hazard ratio, it just crosses the unity. It is actually not yet met its significance. Next slide. Next slide. Now, when we talk of treatment, we need survival, which is probably the most important requirement, along with a good quality of life, which is needed for the patients. So, next slide. Now, why this becomes important is that when you're talking of many of these studies, the headline again was on the PFS, and the PFS was met for both the drugs. However, is PFS really a good surrogate for OS improvement? Now, the STEEP criteria did say that PFS could be a surrogate, but then over time, 7, 8 years, like I said, OS benefit is something that we would like to be seeing. So, next slide. So, let me get in my panelist here at this point. Dr. Costo, do you agree with this statement, or are you satisfied with PFS alone as a good surrogate?
Yeah, so PFS is a good surrogate, not the perfect to choose some drugs, but yes, it is a surrogate for the ways because of the PFS. When we determine how would we consider the PFS, we ultimately time interval we doing the some scans. So suppose that we have done scans after 5 months, but might be the disease already progressed the 2 months after that, before that only. So we cannot able to, determine what is the timeline in that case. So it is a surrogate, but not that ideal.
Okay, so it's a surrogate, but not the ideal surrogate, is what you're saying. Very good. Dr. Pradeep, do you agree with that statement? It's a surrogate, but probably not an ideal surrogate.
Yeah, yes, sir. It's definitely it's not the ideal. So overall survival tells so lots of things. So patient's quality of life, how patient has tolerated the drug, what are the next line of treatment. So there are different other things that is included. So probably when patient is overall survival will look it. So it is a better marker probably.
Okay, Dr. Susanta, do you agree with this?
Yeah, no, that's single line test. PFS is not a surrogate for OS,
Okay.
but PFS is an important that milestone for us. That's why we are including on most of the trials. But what is the important of PFS, that whenever a very malignant disease, that deadly disease, we need a new drug. So we need a rapid approval. In that case, we need PFS benefit. That's why few drugs comes only for PFS. After trials, when they failed OS, we remove that drug. But it is for that reason PFS is important. Till now, most of new trials included primary endpoints as PFS and secondary endpoint is OS. So till
Okay.
now,
So,
but for an older drug, PFS is not a surrogate marker for OS.
all right. So, if I can just ask, act as a devil's advocate, I mean, there's a situation where you don't have an OS still for a lot of the. I mean, that was the idea behind why we spoke of PFS, because we know in a breast cancer you are going to get a lot of time for getting OS, which is exactly why PFS was selected as the headline. But in a situation where you already have now OS in all the three studies, I mean, the way I would look at it is yes, PFS is fine if you did not have OS, but when you have three studies, all of which have published their OS, then really OS is something that we would be looking at. So I think that's just a way of looking at it. That when you have the OS, then OS becomes importance. Probably smaller studies, newer studies, you would be okay to just try with a PFS if you did not have the OS still. That's the way I look at it. Next slide, please. So, talking of the mechanism of action, next slide. Obviously, all the three drugs, though they are similar, do have some slight side effects. And this is again important. Again, this is historical for us in the last 3 or 4 years that we were talking about, and we were discussing about how one can replace the other. But every time the idea was always that these drugs are not the same, they are not biosimilars to each other. They are similar drugs in a same class, but they are not the same. Next slide. For example, when you have CDK4/6, the 4/6 ratio matters. The difference in the on and off target binding would impact the activity of different CDKs as well. Next slide. So again, the drug availability would be important, deciding how the drugs are going to be used. So next slide. So again, coming back to my panelist, Dr. Pradeep. So what are your thoughts on the different mechanism of actions? First, we'll talk of efficacy, and then what about the safety? So, Dr. Pradeep.
Yeah, of course, that CDK4 is the most determined factor. So the drug, how much it is targeting the CDK4, that is one of the important surrogate. So probably CDK4 targeting effects is for ribo and palbo is that's nearly similar probably. That off-target effects are less in ribo and palbo, but that is abima is little bit higher. So basically that CDK4 6 efficacy is depends upon that how specific is spot is CDK4. So definitely that efficacy is important, and there should be less off-target effects also, so to reduce that toxicities.
Dr. Kaustuv, your thoughts on this? Does it really matter? The off-target and the mechanism action is slightly different. Does it matter for you?
Yeah, basically the off-target will ultimately, considering the fact that there will be the least safety, problem will be there when there is less off-target mechanism will be there. And among them, the ABEMA, as Dr. Pradeep has mentioned, is more off-target things are there. So there is a few side effect profile are more than that of this Ribo and this Valvo. But otherwise, this is CDK and the CDK4. This is the most important things among all
Okay.
the kind of things.
Dr. Sushanta, your thoughts on this?
Yeah, that
Hello?
the thing is that here there is the difference in the mechanism of action. All three is that one is potency, for the specific target that like CD4 or 6. Another is off-label targets. So these two factors are different in three molecules. So, if patient the molecule is attaching with that more effect on the off-label target, that's a more side effects. So side effect also varies on this also. So if I give the example, the palbociclib is more neutropenic. Ribociclib, there is ECG changes, and for the abemaciclib, it is the diarrhea. So because the off-label target are very different in three molecules. So the question coming to question, so there is definitely different mechanism of action resulting difference in efficacy and the safety. So this is my conclusion.
Completely agreed with all the panelists. I have to say that, one of the things is, I think that whole discussion, we have to accept that Palbo is not as effective. I know there are a lot of Palbo drugs available. I know we use it a lot. I mean, myself included, we would use it when forced to, but that's really not by choice. I mean, if you're given a patient who can take, we would definitely push for either a Ribo or an Ibima in some cases, because the idea is these mechanisms are different. The drugs are not equally effective. It comes back to what I said in the beginning, that these drugs are not same. They're not like biosimilars that you can substitute one for the other. And that's something we have learned. You have to have a situation where individual drugs have been used in trials before we can really go for it. So next slide, please. So coming to the guidelines, next slide. Next slide, please. Yeah, go back to one slide. One slide back. So the reason why we bring, again, a lot of times we have this doubt: should we really rely on the NCCN? Should we rely on ESMO? But it is a fact that these guidelines give us a certain idea what is better, and the data analysis has been done by these guidelines and gives us an idea. So when you look at it, category 1 is ribociclib. The reason being, of course, that ribociclib has an OS advantage in the first line. That is not something that is shared by Abima. So definitely the OS advantage makes a difference when you consider it being a category 1. Next slide. Again, the ESMO MCBS, which I always take with a pinch of salt. I mean, I know, but a lot of people think that MCBS is excellent because it adds on other factors other than just the results. It does include cost, which in India has a totally different connotation as compared to the West. So, nevertheless, Ribo has a ESMO MCBS of 4, which is one of the better ones. And Abima has 3. Palbo, of course, is lower because, well, like I said, I think it's time to accept that Palbo is not the same as Ribo and Abima. Next slide. So again, the ABCS also shared a similar thing, that because of the OS advantage, probably Ribo is something that can be considered as a more frontline drug. Next slide. So again, let me ask again my panelists, Dr. Pradeep, do guidelines matter, or would you individualize the guidelines? How helpful are guidelines in your practice?
Yeah, of course, that guidelines give you some idea. As sir, you have mentioned that basically they analyze the data and probably they have given that what is the evidence. So sometimes that we definitely that we look into that our response in our day-to-day practice. So that is also matters. So clinical data's my own that understanding about that how the drug is responding, how it is. So definitely that guidelines give us some idea, but also but I look into what basically that patients are responding, how basically patients are responding to Abema, that Ribo, Palbo, that is also matters.
Right. So individualizing, but based on the guidelines. And
Yeah.
any preference for the guidelines, or you are comfortable with any of these guidelines?
Any of these guidelines.
Any of these guidelines. Dr. Sushanta, same question for you.
Yeah. That guideline is we have to guideline is based on the our trials. So definitely we following the guidelines. Also we have to apply our clinical that is what you present, that real world data. That how we are like abemaciclib and ribociclib. That many people told that abemaciclib of diarrhea, but in our things that's not happening. In
Okay.
ribociclib, that many people told that there is many issues, but last 7-8 years I am giving ribociclib. I don't find any patient having any ACG changes.
Okay. Okay.
So this is my point. So guideline definitely we have to follow that, but along with that we have to see our clinical experience.
Dr. Kostov, this is your thoughts on, because he has brought about a very interesting point that yes, it matters to guidelines, but these are Western guidelines ultimately. The same point as we not directly copy them. Definitely, some real world evidence from India, own personal evidence would also help.
Yeah.
What's your thoughts on that?
Basically, the guidelines I already mentioned. The guidelines comes from the evidence. But one thing we should consider of the fact that we know everything, all the drugs are available fine. But the how the drugs to be given to the patient is the patient is affording first, because we maximum time we got this issue from the patient and attendant. They know I am not affording for this. For example, if I consider for the Ribo in the first line in the metastatic setting, but the patient is not affording, you should consider that from the pelvo, because we don't have any other options. So this is also should be taken in considerations, because we cannot give in the extra burden to the patient in that setting. And otherwise, other things I accept whatever the other panelists have told already.
Perfect. I think that's how people are basically saying that we are going to follow guidelines, but we will also rely on our own judgment as well as our own experience. So next slide, please. So quality of life matters. Next slide. So the quality of life, the summary of the QOL data, when you look at it, actually Ribo does have a more data as compared to the other two drugs. Next slide. And the common AEs, as was commented upon, again, these AEs are coming from international studies. And while they are consistent, we do see differences, at least in India. And I completely take your point that the ECG changes are something which are not common. I mean, we have seen side effects with Ribo, but they're not really that bad, is what we have seen. So, Dr. Sushanta, quickly, what is your experience with Ribo side effects?
Yeah, I am very much comfortable with ribociclib. That I have not facing any problem. That not a frequent. That like neutropenia is not
Okay.
happening. Even and another thing is ECG changes not happening. Though because of guideline, I am because of guideline I am doing regular ECG for my patient.
Okay.
And another thing about the particular side effect, I am very much worried about ribociclib. It is the liver dysfunction.
Okay, the
Because
liver dysfunction is something that I think we all are kind of worried about. Dr. Pradeep,
the,
your thoughts on this, your experience with Ribo and the side effects that you face and how difficult it is to manage. Dr. Pradeep? Pradeep is not
Yeah,
there.
yeah.
Okay. Yeah, yeah.
So neutropenia is less than palbo in ribo,
Okay.
definitely. And yes, the liver dysfunction, STLT, the transaminitis is one of the things. And GI toxicities. GI toxicities is common with all that CDK4/6. So that is there.
All
Fatigue
right.
is one thing. Yeah.
But overall, it's a drug where, after a
Yeah.
couple of months, you actually kind of forget to do much testing also. And
Yes,
most, in
yes.
fact, my patients come after 3 months. They don't even come within a month. And though recommendation is, yes, you should check for the bloods, but, many of my patients just come after 3 months once in a while.
Yeah.
Same
Yeah.
experience for you?
Yeah, yeah, same experience.
Okay, perfect. Dr. Kostov, anything specific that you really worried about, or these are by and large as per expectations and the quality of life is pretty decent?
Yeah,
What's your
no,
thought?
yeah, absolutely. In ribociclib, my experience is quite good. I mean, a bit of neutropenia and a fatigue. That's it. I mean, beyond that, even I have not faced any kind of lower GI toxicity also. Yes,
Okay.
LFT derangement is also there in few patients, but no
Okay.
lower.
Not so much. Perfect. I think that's the take home message from all of us, that the drug seems to be pretty well tolerated, not really causing much trouble. Excellent. Next slide. So again, there were some MAICs which look at it, which MAICs, of course, we always take with a pinch of salt. So next slide. Next slide. So again, the trials also are showing, and this is something that we really should, admire the company for doing, that you have such wealth of evidence in all situations using ribociclib, and it does show the good quality of life. Next slide. So again, neutropenia, we spoke about this, that while neutropenia is again something that you're worried about, it's mostly seen in the earlier cycles. And once you really are in that, sequence of taking drugs is really not such a big challenge. Next slide. Next slide. So regarding special populations, again, this is where we sometimes discuss as to which population tolerates it well or not. So next slide. This is just an example of a lady who is, next slide, please, of an elderly patient who is 76-year-old with good ECG, with good PS. Would we still consider for a CDK4 inhibitor? Anyone has tried ribo in such a situation? Dr. Kaustubh?
Yeah, basically, I have two such patients. One is 82 years and one is 77 years.
Okay,
So they are really tolerating well. So I
perfect.
have no problem
I
any kind of.
Excellent. Dr. Pradeep, it's the CGA that matters. If they're fit, then they will tolerate the drugs. Maybe slight dose reductions, but they should be able to manage. Is that
Yeah,
your
yeah,
experience?
400 maybe that good choice
Yeah,
for that.
perfect.
Yes.
I think that's I think been my experience as well. Dr. Shushanta? Dr. Shushanta, you're there?
Yeah. I am here. Sorry, what is your question?
No, I was asking that do you have any challenges in using in the elderly? Because typically that's one area. Yeah, go ahead.
Just I finished my daycare round now, just to join here. I have today the patient is exactly 76, 78-year-old lady having a
Yeah.
ribocycline that is on 400 mg last 3 to 3 years.
Perfect. I think that's the experience that all of us have.
Yeah,
Everyone has a handful of patients who tolerate it really well. So age really does not matter for us. I think that's
yeah.
the conclusion. Next slide. So I'll just go a bit fast, the last 3-4 minutes. Next slide. So treatment considerations are difficult, but then again, in the studies, ribo works for elderly. And I think more importantly, like we have been saying, our own personal experience also matters. And we have seen that personal experience, it works for everybody. We don't really have a big challenge, even just because of the age. Next slide. So again, next slide. Next slide. So just these are all slides which are showing you the real world effectiveness and real world data. So you have the complement, you have the Ribana study, you have multiple studies of ribociclib where, like I was saying, the data is kind of overwhelming. Next slide. Again, next slide. All right, next slide. Now, compared to ribo, probably this is the patient where we would be a little scared to use things like Palbot. They do cause more side effects. At least that's been my experience. So I don't think at this point any of us would be happy to treat a patient with ET alone. We would at least give them the option of starting some kind of CDK4/6. Next slide. Next slide. Next slide. So again, Dr. Pradeep, this is something that we have talked about earlier. I'm not sure it's really a challenge now. Whether that liver mets matter separately, special population you use a separate CDK. Is that something that is still a concern for you?
Yeah. Of course, in visceral metastasis, I will prefer using ribociclib because even in the visceral crisis, few of that visceral significant liver, significant visceral involvement, ribo has the data probably. But if patient is fit for visceral crisis, I would like to use chemotherapy initially.
Okay.
Otherwise, yeah.
That's fine. I think let's not get into the whole discussion of the the visceral crisis and chemotherapy. But my point was that it works in even visceral mets. That is something that we used to initially think it doesn't matter. Yeah, Dr. Sushanto, same experience?
Yeah, that the problem is not the liver mets. Liver, it's okay. But if the patient has abnormal LFTs, the liver function test,
Of course.
the transaminitis, then
Of course.
I am little bit worried to use ribociclib in that case.
Perfect. I think
But
that's true. That's right. That's all of us would be a little worried. So next slide. So this is about again a 59-year-old woman who would have grade 2 AST/LT elevation. Again, remember, a grade 2 means just double. So if it is not very high, you would be still comfortable in using a ribo because it's because of the liver mets. It's not because of inherent liver dysfunction. If a patient has inherent cirrhosis, that's a patient where you would be a little worried. But otherwise, I don't think that's something we really need to worry about. Next slide. Next slide. So again, like I said, enough and more data to show that the safety or the efficacy of ribo in this group of patients is not being in question. We know that it works everywhere and the safety is still there. So next slide. So this was the right choice where they actually looked at patients who were having rapid progression or impending visceral metastasis, where the drug was actually compared to chemo. Now, this is a very subjective thing, so it's a little difficult sometimes to accept. But yes, even today, the number of patients where I would actually give a chemotherapy upfront is, I think, minuscule, less than 5% of patients where I would prefer giving chemo. Mostly, we would still prefer starting off with a CDK4/6 inhibitor. Next slide. Next slide. And again showing the benefit, whereas in the with the ribo it does show a good benefit almost everywhere. Next slide. Next slide. Again, this all these slides basically just showing that if you have an CDK4/6 in patients with visceral metastasis, it does help to give ribociclib. Next slide. Again, next slide. These results were not duplicated by using Palbo or Ebima. So this patient would definitely get a CDK4/6 and we would prefer Ribo in such a case because of the evidence that is there. Next slide. So next slide. So to summarize, CDK4/6 are now the first line standard of care. We do have differences in binding, but again, the overwhelming weight of evidence seems to suggest that ribo is probably the best drug in all the situations and seems to work in every situation. So we would consider continuing ribo in post progression sometimes, though I've not really shown you that data. But overall, ribociclib still remains one of the standard of care for first line HR positive advanced breast cancer. So next slide. I think this is the last slide. So thank you very much. And I thank all my panelists. Over to the organizers.
Thank you, Dr. Vamsi. Thank you, Dr. Sushanta, Dr. Pradeep, Dr. Kostav, for this wonderful discussion. As we all discussed here, ribociclib, I also personally, as Dr. Pradeep also told, we have also used in the aged patient, like more than 80 years. And currently, just 2 months back, one of my patient, 83-year-old, he was in completely bilateral massive metastases. There is a complete response on ribociclib, and from 2022 to 2025, 3 years, she was now able to cook. So many good quality of life she gained. So now, right now, progress. So we have kept on and giving the second line therapy. So moving on the next session. This session is sponsored by the Astra. Um, next session.
Dr. Gunjesh.
Okay.
Dr. Gunjesh, sir.
So welcome, Dr. Gunjesh. He is senior consultant medical oncologist, Paras Hospital, Ranchi. So his talk will be transforming patient outcomes with newer innovative therapies in first-line advanced metastatic hepatocellular carcinoma, the STRIDE regimen, very talked about. So I welcome Dr. Gunjesh, please.
So good evening, boss. Thank you so much for giving me this opportunity. So I would like to share my screen. I hope my screen is visible. My screen is visible now?
Yes, sir. Your screen is
Yes, sir, it's
visible.
visible.
Okay.
Please click on a play button.
Yes.
Yes, sir. Perfect.
Yeah. So good evening, everyone. So today's topic of discussion is transforming patients' outcome with newer innovative therapies in first-line advanced hepatocellular carcinoma.
So, so to begin with, let's start with some epidemiology. And liver cancer is the seventh most common cancer in world, and fourth most common cancer that is leading to cancer-related death globally. So, in around 45% of cases, at diagnosis, liver cancer has spread to lymph nodes or had metastasis. Hence, the prognosis is very poor. In India, according to Globocon data of 2022, the incidence was 38,000, almost new number of cases, while the death was almost similar, like 37,000 deaths were also seen. So in India, liver cancer is the 11th most common cancer type, and 8th most common cancer-related deaths were seen, with hepatocellular carcinoma being the second most common cancer death in men. So this is very important, that male is to female ratio for HCC is around 4:1. So this is the mechanism or the pathogenesis of hepatocellular carcinoma. So mostly the inflammation, immune dysregulation are the key contributors leading to hepatocellular carcinoma HCC development. So there are various etiologies like chronic infections such as hepatitis B infection, hepatitis C infection, leading to chronic inflammation, metabolic syndrome such as NASH, chronic alcoholic abuse such as ASH, and that is leading to cellular death, cellular stress. And these all things are leading to inflammation, dysregulated liver immune network, and further leads to fibrosis and cirrhosis. And we all know that in cirrhotic liver disease is the common background, common niche for leading to hepatocellular carcinoma. And in hepatocellular carcinoma, there is overexpression of CTL4, PDL1, and inhibition of antigen presentation also. So these are the risk factors and pathogenesis of this HCC. So viral infection, HPV and HCV are the most common viral infection leading to HCC. Alcohol, tobacco, aflatoxin in use, non-alcoholic fatty liver disease, NASH, obesity, diabetes, male and autoimmune hepatitis are the common risk factor for hepatocellular carcinoma. So this is the study, and they have shown that the non-alcoholic fatty liver disease is the most common etiology of hepatocellular carcinoma, and it is very commoner in comparison to viral hepatitis. So now coming to proper management of advanced and unresectable cancer. So according to BCLC staging, basically advanced cancer comes under stage C. So BCLC C staging is the most advanced, and we usually treat it with combination of atezo and bev, or durva and tremi in the first line setting, or if it is not possible, then lenvatinib or cabozantinib or single agent durvalumab is also approved. In second line setting, we use ramucirumab, cabozantinib, or lenvatinib, depending upon the previous use of these drugs. And nivolumab single agent is also an option. So when we see the evaluation of treatment in 2007, sorafenib was approved. In 2018, after almost 11 years, lenvatinib and pembrolizumab was approved. Then in 2020, atezo and bev came into picture with nivo and ep also was another option. And later in 2022, durva and tremi is the newer combination option for HCC. So based on the data of SHARP and REFLECT study, that was for sorafenib versus placebo and lenvatinib versus placebo. So the magnitude of benefit in median overall survival was almost 1.5 to 2 months. So there was modest improvement in overall survival, and with the considerable side effect. We all know that these drugs are not very easy to use, because patient can have diarrhea, hand foot syndrome, and lenvatinib can cause hypertension also. So is the considerable side effect associated with both treatments underscore the unmet need for better clinical outcome in management of hepatocellular carcinoma. So this combination came into picture, that IO with anti-VEGF combination, that is IM-BREV 150 trial. It was a phase 3 trial evaluating atezo plus bev versus sorafenib in first line advanced unresectable HCC. So what they found, and there was improvement in median OS and median PFS. So in sorafenib, median OS was 13.4 months, while in atezolizumab it was 19 months, and median PFS was 6.9 versus 4.3 months. So definitely there was significant improvement in OS versus PFS. But when we see the subgroup analysis, there was significant improvement in the other subgroups, but when we see the outcome in non-viral subgroups, so there was not a significant improvement in overall survival. And also, this is the safety and toxicity data. Most common side effect with Tizo and Bev is obviously because of bevacizumab, hypertension and proteinuria as the most common side effect, followed by loss of appetite and diarrhea. So another option is IU-IO combination, and the rationale is that we can target CTLA-4 and anti-PD-L1, so that we can achieve synergistic effect. And durva and tremelimumab increases the anti-tumor activity by reversing the T cell exhaustion and allowing T cell activation respectively. So this study showed that could a single priming dose of tremelimumab with durvalumab improve the immune-mediated clinical activity in HCC, and they found that yes, single dose of treme is actually good and better than combination and of durva and treme for 4 dose. So basically, this is a phase 2 study 22 trial evaluating treme and durva in unresectable HCC, including the stride regimen. So there were 4 regimens. One was T750, that means tremelimumab was 750 milligram, and every 4 weekly for 7 cycles, followed by every 12 weekly. Another was addition of bevacizumab with durvalumab, and one dose was T300 along with durvalumab. That means single dose of tremelimumab 300 mg along with durvalumab every 4 weekly 1500 mg, and another arm was single agent durvalumab. So what they found that this stride regimen, that is T300 along with durvalumab, had the best median OS, that was 18.7 months, followed by single agent durvalumab 13.6 months, followed by tremelimumab, and the 4 doses of tremelimumab along with durvalumab as the least median overall survival benefit, that was 11.3 months. So the longest median OS in study 22 was observed with stride regimen, and more than 3.6 month absolute benefit was seen in median OS, and one event was observed at 27 months in stride regimen, and the stride regimen demonstrated a acceptable toxicity profile and no new safety signals were observed. So after this, a phase 3 randomized data came after this Himalaya trial, that is a combination of durva and treme in first line unresectable HCC. So there were 4 arms. Arm D was discontinued, so they continued with only stride regimen. Arm B, durvalumab single agent, and arm C was sorafenib. So this was the basically the treatment protocol. Single priming dose of tremelimumab plus 1 dose of durvalumab followed by durvalumab 4 weekly was stride regimen. So demographic wise, all the arms were well matched. And when we see the subsequent second line therapies, we all know that if we are using first line immunotherapy, then the options are targeted therapy in second line, while in sorafenib arm, the most common second line was targeted therapy followed by immunotherapy regimen. OS data of stride regimen, OS data of this Himalaya trial showed that there was 10% improvement in 3-year overall survival. So the survival increased from 20% to 30.7 months, while the median OS was 16.4 versus 13.8 months with stride regimen. Also, unlike that atezo-bev data, the stride regimen has improved OS compared to sorafenib across all key subgroups, even in the non-viral subgroups also. Looking into the tumor response rate, the overall response rate and duration of response was higher for steroid compared with sorafenib, 79 versus 20%. And while the duration of response was 22.3 months versus 18.4 months. Again, it was well tolerable compared to sorafenib with lower rates of adverse events, and grade 3, grade 4 adverse events were also lesser in compared to sorafenib. Again, the similar thing, the most common side effects with the steroid were rash, pruritus, and diarrhea. And the treatment-related hepatic or hemorrhagic events were lesser in comparison to sorafenib. So all grades were 1.8%, while 2% was seen grade 3 or more, while it was 6 in sorafenib arm. So after this data, the NCCN has also accepted this could be a category 1 protocol, and this is the recommended combination, the durvalumab and tremelimumab in first line setting for unresectable HCC. So to conclude with my slide, this STRIDE regimen, single agent Tremi and Durva improved the OS versus sorafenib and demonstrated an improvement in 3-year OS rate. And STRIDE was well tolerated with lower rates of discontinuation and GI hemorrhage. So this combination, STRIDE regimen and durvalumab monotherapy also represent the potential new treatment option for patients of unresectable HCC. Thank you so much, and over to the organizers. Thank you so much.
Yeah, thank you very much, Dr. Gunjes, for the nice presentation. And regarding the HCC, as we also have that experience, that tremelimumab and durvalumab, and the fourth term where they have actually used the letter, they have actually omitted 75 mg in 4 doses. So we have also used the 300 mg in a single tremelimumab and durvalumab together. So we have not seen much side effects in patients like in because you all know that metastatic HCG or advanced HCG is a very bad prognosis, and my patients are actually doing well. They have actually, we have done the recent PET CT scan that is also showing good response. So yeah, more patients to include and more our real world data will be matured and we'll see the most of the patients. So next we like to invite our next speaker, Dr. Devmallo Banerjee. He is the consultant and lead oncopathologist in RN Tagore Hospital, Kolkata. So this session is sponsored by Astra, and he will be talking on the HER2 ultra low and emerging frontier in breast cancer treatment. So Dr. Devmallo, please. Dr. Devmallo. Dr. Devmallo has joined, na?
Yes, sir. He's facing issues, sir. Once. Wait, 1 minute.
Okay, okay.
He has rejoined. He will continue his session. Thank you. Demallo, sir, can you hear us?
Yes, hello, I'm audible.
Yes, sir. Kindly resume your session, sir.
Okay, okay. Share the PPT, yes. Hello. Yeah. Am I audible now?
Yes, sir, you're audible.
Okay. Good evening, everyone. Good evening, everyone. Myself, Dr. Devmala Banerjee. I'm very much thankful to Dr. Sanchayan for giving me the opportunity to discuss in this very interesting topic and a new topic rather, and also to the AstraZeneca for their support and all. So now we'll discuss on the HER2 ultra low. It's an emerging frontier in the breast cancer treatment. Uh, Basically, ultra low is a new concept which we can get after the Destiny 6 trials, breast 6 trials, and how it helps the patients in their managements. That we'll discuss in a very nutshells and lucid words, so that everybody we can enjoy their session. Next slide, please. Next slide, please. Yeah. So in Destiny Breast 4 trial, basically, we show that patients who are the hormone receptor positive or negative and who are the metastatic breast cancers with a HER2 low, we compare the treatment with the treatment outcome from the antibody drug conjugates with the physician's choice single agent chemotherapy in Destiny Breast 4 trial and Destiny Breast 6 trial. Basically, there is a metastatic breast cancer who are the hormone receptor positive and who not received any chemotherapy previously. We compare the treatment response in the group of the patients who received the physician choice chemotherapy and the antibody drug conjugates. And I have seen that there is a statistically significant and clinically meaningful outcome in the patients who receives the antibody drug conjugates. So the concept of the ultra low and low, ultra low, this comes in the Destiny 6 trials. Well, in the Destiny 4 trials, basically, there is the concept of the HER2 low. So next slide, please. Yeah. So what is seen that basically, if there's 100 of the breast cancer patients, 15% breast cancer patients, they are actually have the heart, they are the triple negative breast cancer who not express any HER2 or any hormone receptors. 15 to 20% breast cancers, they are basically the HER2 overexpressive, HER2 amplified. That means either they are the HER2 3 plus in IHC or they are 2 plus in IHC and fish or in situ hybridization shows that there is amplification. So, breast 65% these breast cancer patients was actually the negative. This particular group of the patients, we can segregate them as a HER2 low and ultra low by these Destiny 6 and Destiny 4 trials. So this traditional HER2 negative space has evolved to include the HER2 low and HER2 ultra low as an actionable category. That is the most important part of these two trials. So the 65% patients, for them there is a no targetable options are there. Now they can reclassify it as the low and ultra low, and there is actionable drugs are available as antibody drug conjugates for this group of patients. Next slide, please. Yeah, the same things that I have already discussed, that initially the 15% patients, they are the triple negative, 15 to 20% patients, they are the HER2 overexpressive or amplified. And the remaining 65%, 60 to 65% patients, for those where no options were there, no targetable options, now they are reclassified as the low and ultra low group. Next slide, please. So, that is okay that there's a low and ultra low groups, and for these particular groups there's antibody drug conjugates are available. Now, how to diagnose the low and ultra low? What are the challenges as an oncopathologist we used to face during this diagnosis? Is very much straightforward. That we'll discuss in the following slides, and that is the most important component of my discussions today. uh, as an oncopathologist, this is our very much challenges to us to diagnose correctly the low and ultra low category, as the treatments options are different for this group of the patients. So we use as the two important clinical practice recommendation. One is the ESMO consensus recommendation, and another is the ASCO CAP guidelines. So these two recommendations, the two key important clinical practice, help us to diagnose, to stratify these low and ultra low category. Next slide, please. So, leading European pathologists they developed the ESMO expert consensus statements on the definition, diagnosis, and management of the HER2-low and HER2-ultra-low breast cancer. So, in IHC, basically what we see the protein expression on the cell membrane. Now, if the HER2 gene is amplified, then there is a number of proteins are also increased. Normally, HER2 proteins are present on the all cell surface membrane. So the normal breast duct epithelial cells as well as the acini, all the normal breast epithelial cells, they also express the HER2 molecules on their cell surface. Now, when there is a HER2 amplified, then the number of the HER2 molecules increases. So normally, a normal breast parenchyma, normal breast tissue, there has a 20,000 approximately the HER2 proteins on the cell surface. So if there is a HER2 is not amplified, till there is a HER2 molecules present. When the HER2 is amplified, when we can call that is HER2 number of the HER2 gene copy number is more than 6 per cells in when you do the FISH techniques, then you call this is, it can we can say it is a HER2 amplified. In that settings, the number of the proteins present on the cell membrane is equivalent to the 5 lakhs per cell. So normal HER2 genes, the number of proteins are 20,000. When it is amplified, then it is at least the 5 lakhs on their cell membrane. So in between, we have the scoring criteria. So if there is a no staining, absolutely no staining on the cell membrane, then we can call it the HER2 negative or HER2 zero. So according to the 2018 ASCO CAP guidelines, we call it the HER2 zero, and it is a HER2 negative. If we can see in current 2023 ESMO consensus, which basically gives up the idea of the HER2 low and ultra low, they are also telling that if there is an absolutely no staining, then you call it the HER2 null. You don't say it's the HER2 negative, it's the HER2 null. Now, if there is a very faint, barely perceptible staining in less than 10% invasive tumor cells, then according to the 2018 ASCO CAP guidelines, it is a HER2 zero. According to the 2018 ASCO CAP guidelines, it's HER2 negative. But according to the ESMO 2023 guidelines, this is the HER2 ultra low. So HER2 ultra low means when it is more than 0 but less than 1 plus staining. This particular cohort. Now HER2 1 plus means when there's an incomplete faint staining in more than 10% cells. So if there is a more than 10% cells incomplete staining, then you call it the HER2 1 plus. According to the 2018 ASCO CAP guidelines, HER2 1 plus is also considered as a HER2 negative. But according to the 2023 ESMO guidelines, this new concept of HER2 low appears for these particular groups. So who are the HER2 low? HER2 low groups are basically those who has the faint, barely perceptible staining in more than 10% invasive carcinoma cells. But not only that, now I will discuss. I will say which other patients also included in the HER2 low. So till now we are already discussed the what are the HER2 1 plus. Now what are the HER2 2 plus? HER2 2 plus means when there is a weak to moderate staining in the more than 10% of the invasive carcinoma cells. They are the HER2 2 plus. Now HER2 2 plus groups, if you see the IHC HER2 2 plus, there is a reflex testing for the FISH or ISH. So if the FISH techniques are not available, then you can go for the ISH testing also. Both are recommended. So if we see there is a FISH non-amplified, then you can call it the HER2 2 plus non-amplified. And they, according to the 2018, the ESMO ASCO CAP guidelines, the HER2 IHC 2 plus and FISH negative group are also considered as the HER2 negative. So these group also, according to the ESMO 2023 guidelines, are the HER2 low groups. So what you see, the patients whose breast cancer cells have no IHC expressions, according to the 2023 ESMO, they are the HER2 null group. According to the 2023 ESMO, the patients who shows the 1 plus staining or the 2 plus staining and FISH negative, they are the HER2 low groups. In between those, that means the patients who has the faint, barely perceptible staining in the tumor cells, but less than 10% tumor cells, we can call it the HER2 ultra low groups. So this is the changes ESMO 2023 guidelines have made, and we during the reporting, every oncopathologist should show the very strict adherence with this guideline system. So there is a no change in the HER2 positive patients. That means 2018, according to 2018 ASCO CAP guidelines, if there is a strong crisp membranous staining involving more than 10% tumor cells, we call it the HER2 3 plus. Or it is the weak to moderate staining more than 10% tumor cell and FISH positive, we call it the HER2 positive. So these groups, according to the ESMO 2023 criteria, similarly they call it the HER2 positive. So there is a no change in the HER2 positive groups. There is a no change in the HER2 null. But there is a new entity, the low and ultra low comes in between these 60 to 65% patients. For those, no actionable drugs are available previously. Next slide, please. Yeah. So, so this is the ESMO guidelines I have told you. So now what is the ASCO CAP recommendations? Now these ASCO CAP recommendations update, acknowledge a new indication for the trastuzumab deruxtecan when HER2 is not overexpressed or amplified, but immunohistochemically, chemistry shows that 1 plus or 2 plus without amplification by the in situ hybridization. So pathologists can make the best practice effort to distinguish the 1 plus result from 0 by the following good laboratory practice. So what the pathologist should follow? Now examine the HER2 IHC slides first in the scanner. First thing that we have to show very strong adherence with the ASCO CAP guidelines for the reporting that I've already discussed. Second, the pathologist will first briefly examine the entire slide in the scanner. And initially what we see, the 3 plus reporting we can done in the scanner microscopy, but for the 0 and 1 plus, we have to come in the high magnifications to see very meticulously. So any faint, barely perceptible staining is there or not. So examine the HER2 IHC stain slide using standardized ASCO CAP guidelines scoring criteria. Second is that examining the HER2 IHC at high power when we have to distinguish it from the 0 plus or 1 plus. Because 0 null means no staining. 0 plus means faint, barely perceptible staining in less than 10% tumor cells. And 1 plus means the same intensity staining but more than 10%. So it is very much crucial to examine the entire field suspicious area in the high power 40x scanning. So if there is any doubt, though a second opinion from the fellow pathologist, oncopathologist we should take. Okay. Now, using the controls. Now, for this IHC, initially the recommendation of the ASCO CAP is that high positive value control should be used, the IC3 plus controls. But now the recommendation is that as there is a low ultra low concept, we should use a range of the low and ultra low controls for the standardization so that we do not miss the low and ultra low slides in the reporting. And careful attention we have to keep in the slides so that wrong interpretation is should not made. We should not report the cytoplasmic staining. We should not report the artifactual stainings as a 0 plus or 1 plus. So these following criteria, if we follow meticulously, a pathologist follow meticulously, then easily we can segregate the 0 plus or 1 plus from the high C null type. Next slide. Next slide. So that is the basically how to we interpret the IC HER2 IHC. Now how to report it. Next slide, please. Yeah. So one thing I just want to mention that for the IHC, there is a multiple companies and multiple clones are available. The widely used clones or widely used system machine automation for the IHC staining are basically Leica Biosystem. They uses the CB11 clones. There is the HARCEP test or the DACO Agilent system who use the 4B5 clones. There is a Biogenex system and the Roche system. The Roche basically 4B5 clones are we used. And Biogenex system we use the CB11 clones. So there is a different IHC machines and different IHC clones are theirs. And the test result depend on the different machine and different clones. So which machine or which clones we should use? The clones which has the highest sensitivity, obviously we should go for that. And for the manual staining, it is not recommended to use the manual staining for IHC reporting as a low and ultra low. So if you want to use the criteria low and ultra low, you have to use the USFDA approved clones, and the automation should require. So in manual staining IHC, it is not recommended to report the low and ultra low in invasive carcinoma. So next slide. Yeah. So this is the very interesting slide which shows that different clones, different IHC machines in the different staining patterns. So see in these diagrams, IHC pictures. So there is a nice brown membranous staining in the topmost all three images. So most left side is the Leica system. Second one is the DACO system, and the right one is the Roche Ventana platforms. So you see that score 3 plus, they show the strong crisp membranous staining in all these three systems. So in IHC 3 plus positivity, there is a no difference. But when we go in the lower scoring system, that means that 2 plus, 1 plus, or 0 plus, then the sensitivity actually changes. And if we see the slides very meticulously, then see in the Leica system, that is the rightmost one, the topmost bottom also, which is a 0 plus basically, the last one, number 4, one that shows that very faint, barely perceptible staining, membranous staining in few tumor cells, where in the DACO or in the your others, the next system, there is a Leica system, there is a no staining is there. Similarly, that means the intensity of the staining depends on the which machine we are using, which company machine we are using, which clones are we using, and it is much more valuable, much more significant for the lower scoring. For the 3 plus scoring or 2 plus scoring, there is a no gross difference. Next slide, please. But for the 1 plus and for the 0 plus scoring system, definitely the Leica, the Roche platforms is far more better than the Leica and the DACO systems. And the Roche antibody, Ventana clones, that is in superior positions than the Leica or the DACO system. So it is better to use the Roche platforms and the Ventana clones when we are reporting the low or ultra low. Next slide, please. Next slide. Yeah, the same thing I've already discussed. So it is a score 1. See, in the most right one, the intensity is much higher and than the middle one and the most left one. So the most right one is your Roche Ventana platforms and the Roche antibody, which shows the superior sensitivity in reporting. Next one. Next slide. Yeah. So this is the score 0, and score 0, see there is all three systems shows that there's a no staining, absolutely no staining. So actually according to the ESMO 2023 guidelines recommendation, we can call it the score null, not the score negative. It is the score 0, and you can report it as the hard to null type. Next slide. Yeah. So as I have already discussed, that the reporting of the IHC hard to new, particularly for the low and ultra low, the which antibody we are using and which system we are using, that is very much important. So if we go for the ECAS means the external quality assurance systems. So that means there is a different groups, different bodies, associations are there. In our labs, we use the NCG ECAS, that is the National Cancer Grid. NCG ECAS, they send the slides, the quoted slide to us for the staining. And NCG ECAS basically is run by the Tata Memorial Hospital, Bombay. They send the slide to us to run in our machines, with our antibodies. Different labs in India using the different machines and different antibodies. Most of the labs, fortunately, in our country using the Roche platform and Ventana antibody. And it is seen that ECA scores are better with the approved IVD than the IVDs than the LDTs. Okay, so in manual LDTs means the lab developed test. So we can use the manual staining also. We can use the different clones also. But if we use that, then the ECAS external quality assurance program, the result will show the mismatch result. So in our hospitals, we use the ECAS from the NCG, and we see there is a good concordance with our result with the Tata Memorial Hospital ECAS slides, because we are using the ROS platforms and Ventana antibody. Next slide. Yeah. So this is a typical slide for the pathologist, and it's showing that the difference in the staining pattern and intensity between the IHC 0 and 1 plus are very much subtle. So for IHC 3 plus, it is not a problematic, because IHC 3 plus, the intensity of the staining is so high and the number of cells are good in number, so that you can use the 5x or 2.5x objective to pick up. For the IHC 2 plus, 10x or 20x objectives are also very enough to pick up. But for the 1 plus and for the 0 plus staining, every pathologist should uses the 40x objective to not to miss that, because the criteria, the definition for the 0 plus and 1 plus is that there's a faint, barely perceptible staining in less than 10% or more than 10% tumor cells. So to pick up this faint, barely perceptible staining, every pathologist should go in the 40x objective, so that not to miss the single tumor cells with this minimum intensity of staining. Next slide. So HER2 ultra low breast cancer, I've already discussed, is very much challenging, and we should follow the strict criteria ASCO-CAP guidelines. We should scan the slides in the lower power, and any suspicious area we should follow the 40x magnification, not to miss the tumor cells. If there is any confusions, we can take the opinion of the second pathologist also. And another important thing is that there is a cytoplasmic staining. So we should avoid the cytoplasmic granular staining. We should avoid the artifactual staining. So we should not report it as a positive. So we should very much stick adherence with the ASCO-CAP guidelines only, can give you the optimal reporting of the low and ultra low, which benefit the patients in their treatment. Next slide. So now I have already discussed that what is the low, what is ultra low, and what are the criteria to identify the low and ultra low, and what is the ESMO recommendation or the ASCO-CAP guidelines. What now? How to report? Because it's okay that I have identified it is a low or it is a ultra low, but I have to make a report such a way it can be a meaningful. So my clinical colleagues, medical oncologists or radiation oncologists, they can identify that, they can understand what the pathologist want to say, and according to that, they should report. So for that reason, we always encourage the synoptic reporting. So next slide, please. Yeah. So synoptic reporting, why we uses the synoptic reporting, and what is the importance of it? Because the synoptic reportings show the consistency of the data elements. It improved the completeness of the reporting, the accuracy and ease reporting, and the ease accreditation compliance. So template provide the clinically relevant informations when reporting biomarker test. So that's why the synoptic reporting is much more superior than the gross essay type elaborate reporting, because in synoptic reportings the exact information which is very much essential for the next level of treatments was there. So we always encourage the CAP guidelines, ASCO-CAP guideline, the ASCO-CAP reporting format for the biomarker reporting, and as is the biomarker and very much challenging biomarkers. So for this biomarker HER2 also, we always encourage the synoptic ASCO-CAP guideline based reporting. So what is this kind of report? I will show in the next slides. Next slide, please. Yeah. So in a complete synoptic report for the biomarker, particularly for the HER2, so first thing we have to specify the HER2 assay, which assay we are using, because I have already shown you the different assay. Different assay means the different machine automation, different clones have the different result. Sensitivity is different. So someone using the Ventana antibody ROS platforms has a different result for the low and ultra low specifically, not for the ISC positive 3+ coding, but for the low and ultra low than the DACO or the Warmax system. So number one, first thing, specify the HART2 assay used. Second is that what is the score? Is it the 0, it is 0+, 1+, 2+, or 3+? That very much clearly mentioned. Next thing is that if it is the 2+, then the reflex in situ hybridization technique you have to do either by FISH or by the ISH technique. So if the labs which do not have the FISH platform, they can go for the ISH techniques by their IHC automation only. So, but the reflex testing is very much required. Okay. Next thing is that report the complete HART2 status, including the IHC score. So based on your IHC, based on your FISH report, you can you have to mention that what is the complete IHC status. So if the IHC show the 2+ and the FISH show it is the amplified, then the complete IHC status, HART2 status is the positive. That should be there. Then you have to include the estimated percentage of the tumor cell stained as well as the staining intensity. That means the 5% tumor cells show weak, faint staining on the cell membrane, incomplete staining in the cell membrane. So all these adjectives, that is the weak, faint, and incomplete, must be there. And the percentage of the tumor cells must be there because these percentage helps the clinician to identify that it is less than 10% or more than 10%. That means it is a 0+ or it is the 1+. So that's why it is very much recommended. Then the next thing is that conclude the report with the final HART2 interpretation. So HART2 is your null, HART2 is your is an ultra low, it is low or it is positive. That is the final. So these parameters should be there in every ASCO CAP recommend guideline maintained HART2 biomarker reporting. Next slide, please. Yeah. And ASCO CAP guideline update 2023 recommended inclusion of a footnote in a pathology lab report. I am not going in very details. That yellow mark lines shows that is the footnote should be there in every report, so that the patient who are the 3+, that means the IHC HART2 gene amplified, they are benefited from the Herceptin or trastuzumab, but the patients who have the non-amplified levels of the gene expression, that means it is not the 3+, but it's the 2+, or it is a 1+, 1+ or 0+, they are also benefited from the antibody drug conjugates. So that lines, that footnote should be there in every HART2 reporting according to the ASCO CAP 2023 update. Next line, next slide. So this is the CAP reporting template update 2025. It referred that HART2 ultra low as IHC 0+ suggests in the inclusion of a footnote in the pathology lab report. So what is this footnote? That HART2 low was it is that in the DESTINY-based 4 and DESTINY-based 6 trials, HART2 low was considered IHC score 1+ or 2+ ISH negative, and HART2 ultra low was HART2 IHC score of the 0 pattern 0+ with membranous staining, that is incomplete, faint, barely perceptible in less than 10% of tumor cell. So breast cancer with these staining patterns may be eligible for the treatment with ADC, that means trastuzumab deruxtecan, in the metastatic setting. But those with the no staining, that means the HART2 null, are currently excluded. So that footnote is recommended by the CAP in 2025. That you also can use in as a footnote in the every report. Next slide, please. So I have already discussed that what is the low and ultra low, how to test the low and ultra low, what is the definition of the low and ultra low, and what is the different clones, different systems, and how to report it finally. Now, when to test. Next slide, please. Yeah. So we have already known that HART2 is a very much dynamic in nature. The patients whose initial HART2 is the negative or initial HART2 is the low can show the high HART2 expression, amplified HART2 expression in their metastatic disease. The opposite is similar true. The patient who has the HART2 strong positive 3+, they can show the 2+ or 1+, even negative in the metastasis. So the every patient who has the recurrence or the metastasis, the HART2 testing should be done. So next slide, please. Next slide, I will show you that who are the exact number of criteria for the retesting. Next slide. Yeah. So these are the different. No, sorry, previous slide, please. Yeah. So thank you. So these are the different group of the patients where we should go for the HER2 retesting. Number one, in the recurrence and or stage 4 HER2 negative breast cancer patients. So HER2 negative breast cancer patients, stage 4, who have the recurrence, from the recurrence or metastatic sites, the HER2 testing should be done. When the receptor status of the primary tumor is unknown or it is negative. Next is if the primary tumor is heterogeneous for the receptor expression. So HER2 is heterogeneous in the breast cancer. In the gastric cancer also it's heterogeneous. It is much more heterogeneous in gastric cancer actually. So in the breast we see there is some area 3+ positive, some area 2+ positive. These type of the patients, the retesting is very much important. Next, if the metastatic evaluation is unusual compared with the tumor characteristic. So you have seen that the patients who initially have the different behavior, now the metastatic side, the behavior is much more aggressive. Then we should go for the HER2 testing. If the new therapies become available, if the initial test was performed more than 10 years ago, then from the recurrent sites or metastatic sites, the HER2 retesting should be done. If the infrastructures can support safe and timely biopsies with the short turnaround times, we should go for the HER2 retesting. So these are the different criteria for the group of the patients for the HER2 retesting is very much essential. Next slide, please. Next slide. Yeah. So rescoring is very much important because the initial patients who are the IHC 0, the historical IHC was 0, the rescoring shows that there is a good number of patients, they shows that HER2 low and ultra low. So that's why the patients who historically was diagnosed as a HER2 0, the rescoring by the oncopathologist should be done so that they can show the HER2 ultra low in low groups and they can fit for the antibody drug conjugates. Next slide. Yeah, the same things that prevalence of HER2 ultra low among the patients with the advanced breast cancer with historical IHC 0 status, and it is seen that almost the 45 to 50%, 60% of patients who are the historically show the 0, they are in the different groups when the rescoring is done, either low or ultra low groups, and they can receive the benefit of the antibody drug conjugates. Next slide. Yeah. Now, there's a lots of the pre-analytical factors which influences the IHC result also. So not only that, the different IHC automations, different clones are only important. So there's other things also importance which influences the IHC results. Some are the pre-analytical, some are the analytical, and some are the post-analytical analytical factors. So in brief, I will discuss with you in the following 2-3 slides. Next slide, please. Yeah. So these are the multiple factors. So what are the pre-analytical factors? It is a time of slicing and fixation. So one most important things in our country, the low resource country, and it is the important thing is the time of the fixation and slicing. So once the specimen is removed, as soon as possible, we have to keep the specimen in a 10% neutral buffer formalin. So the cold ischemia time should be minimized and it should be less than 1 hour. So what is the cold ischemia and what is the warm ischemia? When the surgeon operate the specimen, the patients, when they apply the clamp on the artery, so at this and they remove the specimen, this time gap is known as the warm ischemia. And once the specimen is removed from the body and it's put on into the formalin, 10% neutral bar formalin, this time interval known as the cold ischemia. So warm ischemia we cannot alter because it depends on the patient situations, the complication of the surgery and all. But the cold ischemia we can influence. So as soon as the specimen is removed, it should be cut properly so that the formalin can penetrate the specimens, and it should be kept in the formalin. So more than 1 hour cold ischemia influences the HER2 expressions very much crudely, and there is a low and ultra low, particularly the expressions is very much deranged if the cold ischemia time increase more than 1 hour. Another second important thing is the proper fixative. it should be a neutral buffer formalin. So sodium dihydrogen phosphate buffer must be there in the fixation. So most of the labs, as it's a low resource country, and most of the labs do not use the buffer solutions, and the pH is not maintained. So they show that pH is the higher range pH, alkaline pH. So in that case, the fixation is not proper, and the staining of the HART2 definitely changes depending on these factors. Second is the method of tissue processing. If you go for the manual tissue processing, the HART2 expression can be changed. Automated tissue processing with the different protocols can influence the HART2. So we always follow the protocols which used in the Destiny 4 and Destiny 6 trials if we want the optimum result. So that should be followed. Next is time of fixation. So small biopsy, the fixation time should be minimum 6 hours. If it is less than 6 hours, definitely the report will be changed, and it should not be more than 72 hours. If it's a small biopsy, if it is more than 72 hours or fixation, then obviously your HART2 expressions will be changed and it is the wrong reports. Next is your what assay you are using. Either you are using the Ventana Roche platforms, Ventana antibody, or the OneMax platforms, Leica antibody, or the DACO platforms and the Azilin antibody. Depending on that, your IHC result will change. Already I've discussed with it. So equipment calibrations, laboratory procedures, staff competency, type of the antigen retrievals, test reagents, control we are using. For the IHC 3 plus or IHC negative, these two spectrum, the high positive control is okay. But now the current recommendation is that as we are using in our every report, the low and ultra low, we try to give the low and ultra low value in the every reports. The range of controls, range of low controls should be used. That is one important factors. If we are using the digital pathology, digital platforms, so the image when scanned and it's analyzed in by a pathologist in the remote center, that the digital pathology platforms are using, then the calibrations of the systems and the proper optimal calibration is very much important for the optimal evaluation of the images. So interpretation criteria. The pathology should have the strong adherence with the ASCO-CAP guidelines for reporting the HART2 low and ultra low. So these all are the parameters. These all are the factors. Some are the pre-analytical, some are analytical, some are the post-analytical, which influences the HART2 results. Another important thing is that the way how we are preserving the blocks. So if the blocks are kept in a very hot, humid area for the long time, definitely the expression of the HART2 is changed. So for the more than 10 years, the blocks, it is not recommended to go for the HART2 testing. In that case, the rebiopsy is recommended if the patient come out with the recurrence and the metastatic disease. So all these factors that influence the HART2 results. Next slide, please. Next slide. Next slides. That all I have discussed already. Yeah, that is a cold ischemia. I have seen you. If the cold ischemia is proper, see the top one is show the IHC expressions. So it is almost all the cells show the nice positive membranous staining, strong intensity, crisp staining, just like a fish nest pattern, almost in one of the 100% cells. But in the lower, when the cold ischemia is at 2 hours, more than 1 hour, see almost the 80% cells, they lost the IHC expressions. So that is the difference. Similarly, for the fish, the next image, if you see the HART2 fish, the pattern, see in the topmost image, the green images, they are the HART2 signals. So they are the cluster of the green images. They are so much expressive, so much HART2 amplified. But in the lower, they lost these signals. So the cold ischemia, one of the very vital factors I always tell, the time of the fixation and the type of fixation, that all influences the HART2 results. Next slides. Yeah, there is a storage. So if the properly storage blocks, the HART2 expression is excellent. If it is a storage very badly in a hot, humid environment for the long times, obviously the HART2 expression will change. Next slide. So these are the take-home messages that I've already discussed to you. That what is the HART2 low and HART2 ultra low, how to interpret the low and ultra low, and why it is recommended to reclassify the patients in the low and ultra low, how they can be benefited, what are the scoring criteria, and what are the different factors, pre-analytical, analytical, and post-analytical factors which influences the HER2 expressions and interpretations. Next slide. Thank you very much for all of your patience. Any queries is highly appreciated. Any questions or any queries?
Yeah, thank you so much, Dr. Debmallo, for your elaborated this topic.
Thank you, sir. Thank you.
And we know that in this advent of this antibody drug conjugate, now this trastuzumab deruxtecan or other drug conjugate actually ensuing in the market. Actually, the previously antibody drug conjugate that we have been used for long, trastuzumab emtansine, now came up with this trastuzumab deruxtecan had really changed the scenario and the survival.
Yes.
And for our personal experience, we have seen that there is a marvelous response of this wonderful drug. Even I have some patients on deruxtecan that they have the brain metastases,
Okay.
and that also in low HER2 expression, not the 3 positive as you have told.
Okay. Okay.
So we have seen that being an extensive disease stage 4, even the brain mets also get a good response of this deruxtecan molecule. Now, I just have some one doubt that whether you can just clarify. Suppose one patient has a HER2 3 positive full expression, and
Yes.
suppose as you have shown that one patient has a suppose HER2 ultra low, like 0
Plus.
with some membranous staining less than 10%
Yes.
and less than 10% as 1 plus.
Yes.
Is there any difference in the response of the trastuzumab deruxtecan or like antibody drug conjugate regarding this 3 positive and the ultra low positive? Is there any morphological difference if we use in case of the response in the stage 4 cancer? Any comment?
Sir, truly speaking, 3+ patients they receive is the Herceptin.
Like just Dr. Demal, just I want to comment, sir. There is a one concept is coming also. You also know that hot tumor and cold tumor,
Yes.
right? That we are using the immunotherapy. Those tumor who are highly immunogenic is called hot tumor, and same like cold tumor being expression PD-L1, but they are not responsive. That's why further classification has been done. Now, my question is here, same like a hot and cold in immunotherapy, whether this 3 positivity and this 0 plus, whether there will be difference in the response also.
Response. Okay. Sir, truly speaking, if you ask me my experience, 3+ patients receiving the Herceptin, I have seen the excellent response. Almost complete pathological response in a good number of patients. The exact percentage I cannot say. And mostly interestingly, the invasive cancer, they show the maximum response. The DCIS, they persist. I do not know what is the exact reason for it, pathogenesis behind it, but DCIS persist, but the invasive cancer component for the 3+ HER2 expression, so the excellent response. But till now, I have not seen a single patients in my hospitals who are the 0+ receiving the ADC, and I have not seen any post ADC patients who have the 0+ or 1+. So 3+ patients are definitely complete pathological response. I've seen a lots of patients. DCIS definitely show some resistance to the Herceptin, but 0+ I have not seen. I have no experience directly. I have not seen any patient.
Okay, so I think the real world scenario will make more robust data if we have a case series, and then we can actually analyze the gene expression so that we can actually know regarding the hot and cold.
Exactly. Once we used to see regularly the cases with the 0+ taking the ADC, and then we can make this comment. Currently, sir, I do not have any actual experience.
Okay. Thank you so much.
Thank you.
So I am calling my next topic, next speaker, Dr. Tomojit Choudhury. He is a consultant medical oncologist in Apollo Multispecialty Clinic, Jamshedpur. and he will be talking on the breaking the frontier in first line metastatic non-small cell lung cancer, leveraging the anti-PD-L1 and anti-CTLA4 for high unmet need patients. Dr. Tamojit, please.
Good evening, and thanks to Dr. Shanchan for this opportunity and for this platform. Hope I'm audible clearly, and
Yes.
requesting for sharing the slide deck from your end, Mr. Daud. I already shared the slide deck.
Okay, sir. Okay. Tech team, please stop the recording for this session.
Yes, visible. So thanks to organizers again. Thanks to Dr. Shanchan again for this opportunity. For next 20 minutes, what I'll try to convey is that for oncogenic driver mutation negative advanced NSCLC patients, there is a role of dual IO with or without a short course of chemotherapy in oncogenic driver mutation negative metastatic NSCLCs. And there are two landmark studies which paved the approval for this particular indication. And that will be the primary focus of today's discussion for next 20 minutes. Next. Yeah, so it's basically breaking frontiers in first-line metastatic NSCLC, leveraging anti-PD-1, which is nivolumab, and anti-CTLA4, which is ipilimumab for high unmet need patients. Next. So, next. This is going to be the roadmap for today's discussion. We'll discuss the etiology and then various pathological types. And primary focus would be the IO-IO combination with the two different IO, although these are both are checkpoint inhibitors, but they have a very distinct mechanism of action, but at the same time, complementary mechanism of action. The two landmark studies we are going to discuss, one is CheckMate 9LA, which is again a global phase 3 randomized control trial. And the second one is the CheckMate 227, only the first part, which is a PDL1 positive population. Next. So bit of epidemiology next. So as we know that lung cancer globally as well as in our country, incidence when mortality wise, it is one of the most common. Globally, it's the most common. Next. Yeah, so most common both incidence wise as well as cancer related death, means cancer related mortality wise also. Next. And when you talk about our country data, near about 90% case fatality rate, new cases detection 72,000, 63,000 died of this disease. Next. And in terms of mortality, so only lung cancer related mortality is more in comparison to the combined mortality rate of colorectal, breast, and prostate cancers. Overall, among all cancer related mortality, 1 out of 5 patients died due to lung cancer, roughly around 19% of all cancer deaths. Next. So this also we know that 15% of cases are small cell lung carcinomas and rest are non-small cell. Among non-small cell, there are predominantly adenosquamous or large cell. Next. So I'm not going to the details. Next. So in terms of primary stage of presentation, as we all know that in our clinical practice, majority of our patients present in locally advanced disease or in stage 4, means metastatic disease. So globally, 57% of the patients in SLC present in the advanced metastatic stage, where the 5-year survival is less than 10% when treated with non-immunologic drugs, that means with conventional chemo drugs. Next. So there is an unmet need of the first line therapy, particularly in oncogenic driver mutation negative patients, because we know that for an oncogenic driver mutation positive, for which is very common for adenocarcinoma histologies, we have various targeted therapy options. With them, the median survival can be increased as high as more than 3 years or up to 5 years for some certain mutations. But that is not true for oncogenic driver mutation negative patients, which are predominantly treated with chemotherapies, which is histology driven with or without immunotherapy. Next. So despite the recent advances, there is a severe unmet need in the treatment of advanced NSCLC patients who do not harbor any oncogenic driver mutations. Main problem is lack of durable response, and even particularly for certain subgroup of patients, like PDL1 less than 1% expression, when we treat these patients with either chemotherapy or chemoimmuno combination. Next slide. So mechanistically, there is a very distinct mechanism of action is there between anti-PD1 drug, which is nivolumab, and anti-CTLA4 drug, which is ipilimumab. But these have a very complementary mechanism of action. Next. So because the primary site of action of both these drugs are different, anti-PD1 drug nivolumab, they act predominantly on the tumor microenvironment, and they cause the destruction of the already pre-existing anti-tumor T cells, the function of pre-existing anti-tumor T cells. And anti-CTLA4 drugs, they predominantly act on the lymphoid organs on the peripheral system, and they induce the de novo anti-tumor T cell response, as well as including the restoration and the propagation of the memory T cells. Next slide. So obviously there is a synergistic mechanism of action, depending on they act on tumor microenvironment or restoration of the T cell function, or they causes the induction of and proliferation of new T cells, including memory T cells in the peripheral system or in the lymphoid system. Next. Next. So this is basically the CheckMate 9LA data, which we are going to discuss in the subsequent slides, the 5-year updated overall survival data. Next slide. So this is basically the design of this study. So stage 4 or recurrent NSCLC, no prior systemic therapy, no common oncogenic driver mutation positivity, good performance score, and stratification based on the PDL1 less than versus more than 1%, gender and histology, 1:1 randomization between IO combination with only 2 cycles of chemotherapy. The IO combination, look at the dose, it's a bit innovative. The ipilimumab dose is a bit low. It's only 1 mg per kg and every 6 weekly, not every 3 weekly. The Nivo dose is standard, 360 mg every 3 weekly. And along with that, addition of only 2 cycles of chemo. Now, what chemo to be given is decided by the histology. So if it is an adeno, it's pemetrexed platinum. If it is an squamous, it is always taxane and platinum, predominantly paclitaxel and platinum. And the control arm or the comparator arm of the standard arm is 4 cycles of histology-driven chemotherapy with allowance of the maintenance chemotherapy with pemetrexed, particularly for non-squamous histologies, and treatment given until disease progression or unacceptable toxicity or maximum up to 2-year duration. The primary endpoint was overall survival. Secondary endpoints were PFS and ORR as per the BICR assessment. Next slide. So there is a very balanced demographic parameters at baseline between the 2 arms, the experimental and the control arm, in terms of all various predefined and exploratory factors, including the PDL1. Next. Next. Now, when we talk about the primary endpoint of the ITD population, it's the overall survival. And the long-term data suggests that not only the median overall survival is significantly better in the experimental arm with a hazard ratio of 0.73, but if you focus on the various landmark time points like 24 months or 48 months or even more than 5 years, there is a very clear-cut separation which is maintained in the long term, in the long follow-up, favoring the experimental curve. Just look at the tail of the curve after the 5 year of median follow-up of the experimental arm. It got almost plateaued. That again signifies that there is a long-term good amount of carryover effect of this regimen even after stopping the drugs after 2 years of therapy. Next slide. So similarly, like the ITD population, when we focus on the different subgroup population like PDL1 less than 1%, next, or PDL1 more than 1%. Next slide. Next slide. Next, yes. So squamous histology. Next slide. And non-squamous histology. Next slide. And all randomized patients. So irrespective of we take it as an ITD population, we take subpopulation based on the PDL1 expression less than versus more than 1%. We take the subgroup based on the histology, squamous versus non-squamous. The clear-cut separation of the curves favoring the experimental arm is pretty much well maintained. Next slide. And similarly, like the primary endpoint, which is the overall survival, for all other secondary endpoints like the PFS, like the duration of response, also in the ITD population, as well as the various subgroups based on the histology and based on the PDL1 assessment, The experimental arm always scored better than the comparator arm with a very significant hazard ratio. Next slide. And just look at the tail of the curves of the each and every subgroup and the ITT. Next slide. So now one of the significant, very important factor is that which is, means the duration of disease control and the survival outcomes for patients with a PDL1 expression less than 1% and whether there is any variation based on histology or not. So that means dissect out the result of that question, that particular subgroup analysis has been done for PDL1 less than 1% expression patient, which is roughly around 40% of the ITT population. And when we check the survival outcomes based on the histology in this PDL1 less than 1% population, again, just like the ITT population, irrespective of the histology, the experimental arm scored better and the hazard ratio is pretty much significant. Hazard ratio again is relatively better in the squamous histology. Next slide. And similarly, like for PDL1, 1 to 49% of the expression or PDL1 very high expression, more than 50%, again, the experimental arm scored better. Next slide. So this is the tabulation of all the secondary endpoints, which suggested that irrespective of the ITT population or irrespective of the PDL1 expression status or the histology status or even the gender, the experimental arm always scored better, both for primary and all the secondary endpoints. Next slide. Next. Yes, so this is again the data only for the 5-year survivor patients, not for the ITT population. And again, what is evident is that in terms of survival outcomes, in terms of duration of disease response or duration of response or ongoing response at 5 years, experimental arm always scored better in the survivor patients. Next slide. Now, regarding the toxicity, as expected for the initial part of the therapy in the experimental arm, we have added 2 cycles of cytotoxic chemotherapy backbone along with the IO backbone. So in a single liner, there are no unexpected toxicity happened. The IO typical expected toxicities happened, which can be endocrine or non-endocrine. And during for the chemo backbone, the typical myelosuppression or diarrhea happened, which is very easy to manage and as per the standard guidelines. Next slide. So now few of the key subgroup data, including the CNS positive patients. Next. So when we again see the only stable brain mets patients have been enrolled in this study, and patients with baseline brain metastasis versus without baseline brain metastasis, again, in both the subgroup analysis, the experimental arm scored better than the control arm with a very significant hazard ratio. Next slide. And not only the primary endpoint, but also the secondary endpoints like PFS or duration of response. Also, again, the experimental arm scored better with or without brain metastasis. Next slide. Next. Yeah, and intracranial PFS also better than the experimental arm. Next. Now, again, one important factor is the appearance of the new brain metastasis, which again signifies the protection effect of a particular experimental regimen for the development of the new CNS metastasis. So in terms of that, what is evident from this bar diagram is that with baseline brain metastasis, the new development of brain metastasis is significantly lower in the experimental arm, and without baseline brain metastasis, the actual percentage of new brain metastasis is lower in both the control arm as well as the experimental arm, and experimental arm scored slightly better. Next. Now, for the mutation analysis population, so as we have discussed that this CheckMate 9LA actually excluded the patients with an EGFR or ALK mutation, but they can have multiple other mutations which are not checked as an exclusion criteria for this trial enrollment. So predominantly the 4 mutations which present in the ITT population is KRAS, TP53, STK11, and KEAP1 mutation. Next. So when we see the data with respect to these 4 type of mutations, whether it's a wild type or mutated, and whether there is any difference between the experimental arm and control arm in terms of the primary endpoint, which is the overall survival, what is evident is that, again, irrespective of the KRAS mutation or wild type, next, irrespective of the TP53, next slide. Again, TP53 mutated or wild type, next slide. STK11 mutated or wild type, next slide. And KEAP mutated or wild type, there is absolutely no difference in the overall survival in comparison to ITT population. That means, irrespective of these mutations are present or not, the experimental arm always scored better than the control arm. Now, median duration of therapy is near about 6 months in both the experimental and the control arm, and the grade 3-4 toxicity is slightly higher in the experimental arm as expected because it contains a dual IO-IO combination. But most of these immunomediated toxicities are grade 1-2, which are very easy to manage. Next slide. And regarding the spectrum of toxicities, these are predominantly endocrinopathies or dermatological toxicities, and the severe gastrointestinal, hepatic, or renal immunomediated toxicities happen in less than 5% of the patients. Next slide. And one very important aspect is that patients who discontinued this experimental therapy due to treatment-related adverse event, there is absolutely no decrement in terms of 5-year overall survival. Next. So, very significant survival outcomes with this dual IO-IO with only addition of 2 cycles of cytotoxic chemotherapy. 5-year OS rate, all randomized patients, 18 versus 11%, and irrespective of the PDL1 less than versus more than 1, the significant benefit is well maintained. Almost all secondary endpoints, the experimental arms scored better, including all experimental and predefined subgroups. Next slide. Now, the second part of this discussion is that CheckMate 227, it's basically the first part we'll discuss, which is a PDL1 more than 1% of the patient. Next. So almost similar sort of patients enrolled, just like CheckMate 9LA in the CheckMate 227 also, the stage 4 or recurrent NSCLCs, no prior systemic therapy, no sensitizing EGFR or LAC mutations. Here actually CNS metastasis patients excluded and good performance status. Here the stratification factor was based on the only the squamous versus non-squamous histology. The part 1:1:1 randomization between IO-IO combination, which is again Nivo-EP combination. Second part is the chemotherapy, and the third arm was only nivolumab as a monotherapy. Next slide. Demographic parameters pretty much well balanced. Next. Now, what is evident is that again, when we compare the IO-IO versus chemotherapy, here actually there is one difference in comparison to CheckMate 9LA. Here the experimental arm, which is the IO-IO, means Nivo plus EP, there is no chemotherapy. It's completely chemo-free regimen. So when you compare the IO-IO arm, Nivo-EP arm with chemotherapy on the arm, in PDL1 more than 1% of the patient, the primary endpoint overall survival again significantly better, favoring the experimental arm. Next slide. And all the other secondary endpoints like duration of response and PFS also favoring the experimental arm. Next slide. And there is a clear-cut correlation between the tumor burden reduction and the overall survival. So positive correlation, that means patients who achieved a good response, the survival is better in those population of patients, in the whole population of PDL1 positive patients. Next slide. And almost all the secondary endpoints are also significantly better in the experimental arm. Next slide. Now, one significant aspect is again the correlation between the patient-reported outcomes with the health-related quality of life with the primary endpoint of the study. And what is evident from this Kaplan-Meier curve is that patients with a better baseline health-related quality of life, that means patient with less symptom burden or higher functional scores, the overall survival is better. Next slide. In the experimental arm. And again, in terms of toxicity, no unexpected toxicity happened. Almost all the toxicities which are known to or evident from the other published data of the IO-IO combination in NSCLCs also happened in this in this trial. And predominantly these toxicities happen in the dermatological or endocrinopathies, and rare percentages of serious hepatitis or nephritis or pneumonitis happen. Next slide. So in conclusion, 6-year OS data, 22 versus 13%, and duration of response, 27% versus 4%. Both are favoring the experimental arm in PDL1, more than 1% population. Next slide. Now I'll take 1 more minute to discuss the guideline recommendations. Next slide. So when you talk about the current NCCN guideline, just focus on the category 1 recommendation. There are many recommendations, particularly for PDL1 more than 50% expression patients for both adeno and squamous. But one of the category 1 recommendation is that Nivo-EP along with a histology-driven chemotherapy backbone. For adeno, it's pemetrexed plus platinum. For squamous, it is paclitaxel plus carboplatin. Both are category 1 in PDL1 more than 50% population. Next. Now, when you see the PDL1 1 to 49% of the expression, again, for adeno and squamous, the Nivo-EP combination along with histology-driven chemotherapy is a category 1 recommendation. Next. Now, when we see the PDL1 expression less than 1% population, here actually means for adenocarcinoma, The Nivo EP histology-driven chemotherapy is category 1 for squamous cell carcinoma. The Nivo EP combination plus histology-driven chemotherapy, which is paclitaxel carboplatin, again category 1. So simplistically put, irrespective of the PDL1 expression level, it's less than 1% or 1 to 49% or more than equal to 50%. If we add 2 cycle of histology-driven chemotherapy and add Nivo EP combination as like the dose like the CheckMate 9LA, which is the ipilimumab 1 mg per kg every 6 weekly and nivolumab 360 per mg flat dose every 3 weekly, then these are category 1 recommendations. So with this, I'll stop here. And if any questions, I'd be happy to answer. And otherwise, back to organizers. Thanks to Dr. Shanshan again.
Dr. Tamojit, thank you very much for your in detailed explanation. I just want to have your experience. Like as we all know, that Nivo EP is a dual away combination, as you have explained in your slide, that side effects are slightly higher than the comparative arm. Now, if we see the category recommendation when Nivo EP plus chemotherapy, so dual IO plus chemotherapy is also the treatment of choice. Now, in your experience, compared to this dual IO, adding the ipilimumab compared to the single nivolumab and Nivo EP plus chemo, how is the like tolerance of the patient, and how you decide these patients will go for Nivo IO plus chemo, this patient will go only Nivo, or this patient will go Nivo IO only without chemotherapy? So in your experience, please.
Yes. So basically, in terms of toxicity, the spectrum of toxicity of conventional chemotherapy and IO combination is different. And in CheckMate 9LA, the chemotherapy in the IO combination added only for 2 cycles. So in my practice, I have used this regimen in few patients, and toxicity is really not an issue for this regimen. And second thing, when we combine nivolumab with ipilimumab, if we remember the initial trials of melanoma or renal cell carcinoma, there actually ipilimumab dose is bit higher. It is 3 mg per kg every 3 weekly for 4 cycles. So if we combine that high dose, that sort of dose of ipilimumab with nivolumab standard dose, sometimes the immunomediated toxicities like severe pneumonitis or severe nephritis or hepatitis, the incidence is higher, which are difficult to manage. But for this trial, CheckMate 9LA, the dose of ipilimumab is 1 mg per kg, and that is also not 3 weekly, it is actually 6 weekly. And nivolumab is again the standard dose, 360 mg flat dose every 3 weekly. So in my experience, I have used quite a few number of patients. Toxicity is not an issue. Next, how to choose that which patients need additional 2 cycle of chemo backbone and which patient you can go away without adding chemo backbone. I mean, simplistically put, which patient you want to use the CheckMate 9LA regimen and which patient you want to put on CheckMate 227 part 1 regimen. So when the chance of having a good response is very high with immunotherapy only, and there is no need for additional cytoreduction with conventional cytotoxic chemotherapy. So that simplistically means the patients who are smokers having a high TMB, having a high PDL1 expression, you can still get away without adding 2 cycle of chemotherapy. But for patients who are never smoker in their life, having a PDL1 expression of less than 1% and having a high tumor burden, high symptom burden, I usually prefer to add 2 cycle of chemotherapy.
Yeah, exactly. So nice answer. And another thing, suppose when I have encountered some patient recently, suppose one patient already started chemotherapy on outside of our clinic, like by some clinical oncologist, they have started.
Very common scenario. Yes.
So now they came to you. Now whether you will continue with the chemo backbone along with IO, or you will omit the chemotherapy and continue with only IO.
So that depends actually. Again, the patient if 2 cycle of chemo already received, and we know that the basic rationale of adding 2 cycle of chemo in this trial was that an immune priming effect of chemotherapy along with the cytoreduction. So if the patient already received 2 cycle of chemotherapy or 3 cycle of chemotherapy, good amount of cytoreduction happened, symptomatically the patient is stable, and particularly for a smoker where the immunotherapy for the response is high, I'll stop the chemo and I'll continue with Nivo EP combination.
Okay, and you have given this dual IO and chemo in the single day, or for the fit patient you divide into the 2 day?
Usually single day.
Really? Okay. Thank you. Thank you
Yes.
so
Thank you. Thank you.
So, next, our session will be talked by Dr. Nirmallo Banerjee. He is consultant histopathology in CK Birla Hospital and CMRI and RN Tagore. So, his topic will be HER2 scoring and interpretation in gastric cancer. Dr. Nirmallo, please.
Yeah, so thanks and good evening. Thanks, Dr. Shanchan, for having me in this session. So I just want to share the screen.
Tech team, please start the recording.
So, yeah. So, yeah. So my PPTs are all visible.
Yes, sir, yes.
Yeah.
Yes, sir. Please make it a full screen mode.
Yeah. So I'll make it in a full screen mode. So, yeah. Is it visible now?
No, sir. There is a black screen.
Okay. So, yeah. So now is it visible?
Yes, sir.
Yeah. So, yeah. So today we will try to understand that the importance of the HER2 scoring, its implications in the therapy, and we'll try to understand the biology of the HER2 testing and why there is so much of discussions going on regarding this biomarker. So I have divided this whole topic into two parts. I am audible, right?
Yes, sir.
Yeah. So I have divided into two parts. In the first part, I will describe the normal HER2, the heterogeneity and its effect on therapy. And the second part, we will directly go to the technicalities as far as the histopathology reporting is concerned. So in the first part, I just want to discuss about there are four potential biologically active growth factors in the cell membrane of human body which are playing these oncogenic drivers role. So out of them, although all four are important, out of them this HER2 is getting importance day by day. Although the other partners are there like EGFR and the so-called MET, they are also equally important. But these transmembrane receptors are basically the biological drivers as far as the cell proliferation, differentiation, metabolism, and the cell death is concerned, the apoptosis is concerned. So the aberrant expressions and mutations of these growth factors and their receptors, they play a vital role in the tumorigenesis in the gastric cancer. So basically, when there is an aberrant, or I would rather prefer a term exuberant HER2 expression, and there is a overexpression of these receptors and their dimerizations following without any signal, that leads to predominantly tumor cell growth and proliferation. As well as it has been noted that HER2 positive cells, they are metabolically, they become independent, and the growth inhibition signals has been downregulated from these cells, which is very interesting. And therefore these amplifications takes a role in the gastric cancer, and there is uncontrolled proliferation of the tumor. So a larger cohort has been selected, and it has been noted that these HER2 positivity, which we typically nowadays call as FISH positive or 3+ positive, is noted in the more advanced aged patients who are more than 60, irrespective of the gender, as far as the data I am having. And it is seen more frequently in intestinal, So as for the Lawrence classification, if you divide gastric cancers, it is into two, intestinal and diffuse. Diffuse means there is a lack of differentiation, but HER2 positivity is noted predominantly in the intestinal type. And more than 50% of area, which the case where HER2 positivity in more than 50% of tumor area show worse prognosis than those of less than 50%. An analysis of these clinicopathological features also found that there are grim prognosis in the positive cases and with age and with histopathological subtype. So by this time, we must understand that the positivity is very selective and the age is also a factor. So overall, if you calculate the percentage, it should not cost more than 20%. So if you have 10 cases, only 2 cases will show HER2 positivity, whatever be the positivity. I consider 1 plus positivity is also a positivity. But then in case of GE junction, it is amplified in little bit more, which is 33%. And as I have said, you see the diffuse type, the percentage. Diffuse type means I mean to say signet ring cells. In those cases, their positivity drops down to 5%. Whereas the intestinal type, it is still holds for 30%. So if you are getting intestinal type, the chances of positivity are more. And as far as the guideline is concerned, there are so-called 4 big pillars or giants who describes the guideline. And as per ESMO, they say in all metastatic gastric cancer, go ahead with this HER2 testing. And so does ASCO-CAP. They have said that documented advanced GE junction adenocarcinoma considered to be a good candidate for combination chemotherapy plus trastuzumab. Similarly, the NCCN guideline says that inoperable, locally advanced, recurrent, and metastatic adenocarcinoma of the stomach. So these are the candidates altogether who can be put up for this HER2-IHC. Now, this part is a little bit of difficult to understand, but this is very important to know that HER2 expression in a tumor is never ever homogeneous. It is heterogeneous. It is heterogeneous, and as in the breast also, and whereby distinct subpopulation has to be targeted. Now, why there is a heterogeneity? Now, one common cause of heterogeneity, as we all know, is the concurrent genomic alterations. Now, any HER2 positivity tumor can anytime harbor the concurrent expression of the another RTK, which is the receptor tyrosine kinase, and most commonly PI3K. So therefore, these candidates are will show resistance to HER2 against HER2 therapy, which is trastuzumab. And so commonly, intratumoral HER2 heterogeneity is also not uncommon. Some of the gastric tumor exhibits variations in the level of the HER2 within an individual tumor. That means within a tumor, you will get a clone which HER2 positive and another clone which is HER2 negative. And this is also very important, and there are so much of studies going on, and I will quote a few of them, where loss of HER2, like HER2 targeted therapy based, which is predominantly trastuzumab, after trastuzumab therapy, you will get HER2 negative results. And of course, the acquired genomic alterations, which is relatively rare, however can happen. These acquired genetic alterations means there are some clone which de novo acquire some genetic alterations by which it can show resistance, primary resistance to the trastuzumab. So this is, I am audible, right?
Yes, you are audible.
Yeah. So these are the scenarios where HER2 heterogeneity can be described. Now you can see in this photomicrograph, this left hand side, you can see the same tumor, the right and below, you can see 3+, and above and left, you can see 0. So in the same tumor, the HER2 expression is so variable and heterogeneous that you can easily understand even after a good staining of IHC. And it has been noted that more proximally located tumor and GE junction tumor, the positivity rate relatively increases. So let us understand the statistics and why I'm taking some time to describe this. You see, 25% of the patients who has been previously reported as HER2, now after a few years or after you say kind of 2 to 3 years, if you collect the block from the archival tissues and you compare it with a fresh biopsy, if you have any heterogeneity or any doubt in your mind, so you will see there is an alteration of the result among 25. That means 1/4. That means 1/4. And approximately 9 out of 28 patients, that means 32%, show HER2 down regulations, which means actually physical down regulation is there. It's nothing related to staining alterations. The receptor down regulations happen, and so the upregulations of the HER2 is also there, although the scenario or incidence rate is relatively less as compared to HER2 negativity. Similarly, and interestingly, you see there are two blue boxes here where it has been mentioned clearly that in the same paired sample of gastrectomy of primary and synchronous tumor with metastatic lymph node, you can see in the same surgical procedure the intestinal type of gastric carcinoma where we are getting this 3+ positivity. However, the lymph node is completely negative. So these things are also not uncommon, that primary gastric carcinoma with 3+, however, its lymph node is showing 0 mostly. So this also is a phenomenon. It can happen. And so the opposite, the vice versa, the primary is showing 2+ or 0, it can turn up to the 3+ in the metastatic lymph node. So now the question is that how much heterogeneity we should consider, and testing HER2 expression only in primary gastric cancer may exclude from the targeted treatment with a percentage with a HER2 negative primary tumor but HER2 positive metastasis. So these both phenomenon can happen. So why I am saying this? Because I just want to make these things very clear that even if you test surgically resected tumor, you might get HER2 negativity in an intestinal variant, your metastatic site could be positive or the opposite. So we should be very careful. So let us see the guideline, what they are saying. So no case, I mean the biopsy, endoscopic biopsy should be taken from the multiple sites. This is the only way. One of the way also we can prevent this HER2 heterogeneity, and we can give an uniformity in the reporting of the IHC samples. And no cases should be considered HER2 negative without IHC examinations of at least 2 to 3 sections. That means the primary as well as metastasis when you are encountering an intestinal variant of adenocarcinoma. And concurrent use of IHC and FISH, although it's little theoretical, can help to identify the heterogeneous. We don't do FISH until unless it is 2+. So this all together is the SOPs to encounter this heterogeneity. So it has also been noted that those who are homogeneously positive for HER2, their progression-free survival, their overall survival are much more as compared to who are heterogeneously HER2 positive. They have a significant shorter survival and a lower response rate. So the heterogeneity reflects also in the prognosis, their response rate, as well as in the survival. So when to retest? So then this question comes to our mind, that when should we retest, and the importance of retesting of the HER2 after progression on trastuzumab based regimen, which is even more complicated. That when a patient's on therapy, it is going on and it is showing progression, why and when we should do HER2 retesting. Now you see, it's very also important that HER2 loss phenomenon can increase up to 64% of HER2 positive gastric cancer who have been earlier treated with trastuzumab. So with HER2 positive gastric cancers who are receiving trastuzumab, a significant percentage of patients develop loss of HER2 during the treatment. I mean that it is definitely lesser than the 3+, which was previously reported as 3+. Now it has been downscored to 0 or 1+. So this is a very natural, I mean, it can happen. So as I have said also earlier, that even if you are treating a patient with a trastuzumab therapy, you can get within the course of therapy loss of HER2, and the percentage is 64%, can go up to 64%. So, as I have said, the therapy-related changes in the HER2 is not uncommon, and 30% of the patient altogether exhibit loss of HER2 positivity on post-progression biopsy. On the other hand, 60% had a change in the HER2 expression from HER2 positive to negative. So therefore, if you consider these two data only, that 60% versus 30%. So 60% is showing HER2 change in the HER2 expression from HER2 positive to HER2 negative. And on the left hand side, the 30% exhibit loss of HER2 on post-progression biopsy. So therefore, reassessment of HER2 is recommended at first line progression based on clinical data, suggesting changing in the HER2 status after the targeted therapy. So, as I have said, these positivity and the change in the HER2 status. So, as per the published data, the persistent HER2 positivity, or those who are showing persistent HER2 positivity, they will always show 3+, even on the biopsy and on the resected specimen, even after chemotherapy. And loss of HER2 positivity can be defined as if the biopsy specimen before trastuzumab treatment or HER2 3+, and resected liver metastatic specimen after therapy show loss of HER2 staining, and it can be up to 0. So therefore, now we understand that reassessment of HER2, why it is recommended and why it has been as advised to retest. And it is also important to mention here that approximately 1/3 of the patients who are being treated can show acquired resistance. Again, these genomic evolutions, who was initially tested as a HER2 positive before starting the treatment. So now there is overall this data, whatever is there, now we understand that it is utterly heterogeneous, and we should reconsider the earlier biopsy, we should compare it and reconsider the fresh biopsy also, and then come to our conclusions. So retesting on the HER2 as a whole, if I want to summarize, you can do it in on borderline cases where there is 1+ or 2+ HER2 staining seen by IHCs. Problematic so-called, that means technical problem, that means there is artifact, cytoplasmic staining, cytoplasmic blush without any basolateral staining, and the cases with exuberant, again, this exuberant HER2 staining, because in some cases of surgically resected specimens with a strong, very strong HER2 staining, given the heterogeneous nature of the HER2 is there, in those cases you can do FISH, and if FISH come positive, then you can label it as HER2 positive, because these cases can also create a problem, because the HER2 expression in the gastric tumor can sometimes be too much heterogeneous. So in these cases, retesting is recommended. Now come to the second part and the last part, how to interpret in regular day-to-day practice, how we interpret under the microscope. You see, as I have said earlier, there is 6 to 8 biopsy specimen, the endoscopic punch that which the gastroenterologists pick up and put it on the filter paper. So these 6 to 8 fragments should be taken. Necrotic area should be avoided because it produces nothing. Quick dehydrations is a phenomenon in endoscopic biopsy. We get so much of drying artifact, so much of crenations on the tissues. It should be avoided. It should be put in the 10% NBF. And if resections biopsy, standard SOP should be followed. The so-called pre-analytical factors, which reduces these HER2 expressions, can be minimized. So both IHCs and in situ hybridization have the role, especially when there is a 2+. Can reflex testing of fish is important and can be performed on as far as the protocol is concerned. You can do it on FFP specimen, and staining procedure, it takes 8 to 12 hours, and the as per the guideline, the TAT should be within 4 days. So, and in biopsy specimen, the staining in automated platform, it takes 2 to 4 hours. So 1 day turnaround time is much recommended. So both have their own role. And if we see in the IHC of gastric and the breast carcinoma, the major difference between gastric and the breast carcinoma, where the HER2 has important role. Unlike breast carcinoma, which I want to mention here, the gastric carcinomas are mucin producing and gland forming. So therefore, the circumferential positivity, which is more common in and the most common thing in breast carcinoma, you will never get it in the gastric carcinoma, because the gastric carcinoma cells, the positivity determined by the basolateral staining rather than the circumferential staining. So circumferential staining is for breast, basolateral and lateral membranous staining, or you can say incomplete basolateral staining, is for the gastric carcinoma. So the same HER2 staining, but the protocol is different, because the gastric protocol is related to the basolateral staining, the breast protocol is to the circumferential staining. And if you see here, there's a nice photo has been put here in this slide. You can see all cases of the gastric carcinomas where lateral to basolateral, and some cases if you get the complete membranous staining has been described. However, this, if you consider this as positive 3+, if there is more than 10% tumor cell percentage there, you have to consider this also as a positive. You should not ignore this basolateral and lateral membranous staining as compared to the breast carcinoma. So coming to the criteria and the table, where it has been clearly mentioned that if it is surgically resected specimen, the barely perceptible staining more than 10% is considered as negative, and weak to moderate has been considered as equivocal, and strong, again, basolateral and lateral membranous staining. So this should be considered in your, while interpreting this, as 3+, because it means a lot for the patients. So in case of biopsy specimen, if you are getting it in more than 5 tumor cells cluster, as I have mentioned here, so if you are getting it, you should consider it as a positive. Whereas barely perceptible 1+, you should label it as negative. So FISH testing is only for equivocal part, which is 2+. So this is the...
Sorry to disturb you, sir. Kindly conclude.
Yeah. So there are 4 clones, which has been described earlier also. So these 4B5 and SP3 are the common, which have been used in standard laboratory practice. And these are so-called pre-analytical factors related to these HER2 interpretations. It depends on the temperature, pH, as I have described, these drying of the specimen, type of fixatives, and so by which you can prevent the unnecessary false negative results. So multidisciplinary coordination is a key, of these HER2 positive gastric cancers. So all inoperable locally advanced gastric cancer should be routinely tested. Turnaround time should be uh, responsibility for the histopathology, and it should be as short as possible. And the treatment plan must be formulated with a conclusive diagnosis, and the IC should be run on the automated platform. So this is the reporting protocol, and this is the clone which you are using. You can put a tick that this clone has been used. And key takeaway is the HER2 amplifications is noted in 20% of the gastric cancers, and there is a wide lot of variations in intestinal and diffuse variant. Sampling is a crucial factor. 6 to 8 biopsies from different sites is important. Now, due to the heterogeneity loss within the HER2 loss during the course of treatment, retesting has an immense value. So you must discuss with your clinical counterpart how to do it, when to do it. If both are in same page, then we should go ahead with the retesting. And due to occurrence of possible HER2 loss after trastuzumab therapy, this clinical history or the drug history should be in the requisition form so that any aberrancy of the result doesn't happen. Thank you very much. Thank you. Thank you for your attention. Thank you very much. Thank you.
Yeah, thank you very much, Dr. Devmallo.
Sorry, Nirmal.
Just sorry, Dr. Nirmallo. I just one question that as you told that HER2 loss is important. So how many percent of HER2 loss you have been observed in compared to breast and GI?
The problem is if there is as I have said that only 30% of intestinal variant of gastric carcinomas, they show this kind of positivity. So majority of the cases are negative. So now if I have the history that yes, but although this is very rare, if I have the history that yes, that this patient is on trastuzumab therapy or had received the therapy, then the correlation is better. However, in altogether, not more than 1 or 2 cases which have been seen that during the course of therapy there is HER2 loss is there. But yes, definitely, according to the published data, this percentage are high. Maybe due to the
in breast you also see loss of
absolutely it is. And in breast the variations do occur in archival blocks also. The FISH testings from the archival block is also a very challenging thing, and it's very difficult sometimes to get a appropriate result, to get the signals.
Yeah.
So these are important.
Thank you, Dr. Nirmallo. And
thank you, Doctor.
So next session we are moving on. This is I'm talking about that is the Mark sponsor session. So next slide, please. Next slide. Yeah, my topic is today is the maintain to extend right treatment approach in metastatic urothelial cancer patient. Next slide. Yeah, so bladder cancer, if we consider the incidence wise, India comes on the 7th, and if it is we consider the mortality wise, it comes into 3rd from the bladder cancer scenario. Next slide. So, as we all know that metastatic bladder cancer, whether there is a no role of localized therapy, so we have to give the systemic therapy. Now systemic therapy, with the first line therapy is the platinum based chemotherapy. Now in platinum based chemotherapy, locally advanced or metastatic, guided by the eligibility criteria. Now the Galsky criteria for cisplatin eligibility and Gupta criteria for platinum eligibility. Now one of the following five criteria should be deemed, like cisplatin eligibility is if it is more than performance status more than or equal to 2, heart failure NYHA class 3, creatine class less than 60 ml per minute, grade 2 more than grade 2 hearing loss, and neuropathy also more than grade 2. Now, if it is a platinum ineligibility, that is we cannot use any platinum therapy. If it is a poor performance status like ECG performance status more than 3, NYHA heart failure more than 3, creatine clearance less than 30, low performance status, that is PS2 plus creatine clearance less than 30, and peripheral neuropathy more than 2. Next slide, please. So, rationale for avelumab maintenance in metastatic urothelial bladder cancer. Chemotherapy is used to decrease the burden of the tumor to achieve the disease control and increase the immunogenicity of the tumor microenvironment. So that is very crucial before starting the immunotherapy. So chemotherapy use upfront to make the tumor more immunogenic. And avelumab, the immunotherapy is most effective in patient reduced tumor burden and high mutational burden like urothelial cancer. Now, the cytotoxic and immunogenic effect of platinum-based chemotherapy provide the immunotherapy to enhance the clinical efficacy with immunotherapy maintenance avelumab. Next slide. So this is the most of the patients receive the first line chemotherapy who have the response or disease control. Now most of the patients receive gemcitabine cisplatin based chemotherapies. If it is cisplatin eligible, then carboplatin is used. So 90% of the patient have a control with first line platinum therapy. Next slide. So it is the Javelin Bladder 100 trial, open level randomized phase 3 trial. So they have included the induction therapy with unresectable locally advanced metastatic urothelial bladder cancer. Received the first line 4 cycle to 6 cycle therapy of GemCis or GemCarbo, followed by treatment interval. Treatment free interval is 4 weeks, and then within this radiological assessment of the treatment, and after that maintenance therapy, if the patient is in CR, PR or stable disease, PDL1 positive cases where they have been randomized to avelumab 10 mg per kg every 2 weekly plus best supportive care or best supportive care alone. Primary endpoint was overall survival and primary analysis population on randomized patient or PDL1 positivity, and secondary endpoint was PFS or time to response of duration, disease control, and safety tolerability. Next slide. So baseline characteristic, median age of 68, male or 76%, performance status was good. They have taken location, visceral mets were 55%, non-visceral mets of 45%, and first line therapy 52%. They have used the GemCis and GemCarbo 42%. Next slide. So median OS measured from the start of the chemotherapy, 30 months from the median overall survival benefit with avelumab maintenance at the start of the first line chemotherapy. So it has been seen 9.2 months improvement in median OS, and there is a 23% reduction in risk of death, being the hazard ratio 0.7. And it has been seen that from the 8 months onwards, there is a separation of the curve. Next slide. So if you consider the median PFS data, which was also longer with the avelumab and as a first line maintenance with the best supportive care versus best supportive care alone, where there is a separation of the curve starting from the 4 months onwards, and it has been seen delta is around 10%. The overall population, the risk of disease and progression reduced by 46% in avelumab arm. Next slide. So first line chemotherapy regimen affect the outcome of ability maintenance. Now they received the GemCis or GemCarbo regimen, treatment free interval 4 weeks to 10 weeks. If the patient in CRP or stable disease, then patient put on avelumab. Next slide. So overall survival benefit is maintained in avelumab seen from the start of the first line chemotherapy, regardless the chemotherapy regimen, whether they have patient receive GemCis or GemCarbo regimen. Next slide. Now, does response of chemotherapy matters before starting the avelumab maintenance? Next slide. So, OS and PFS benefit with avelumab seen irrespective of the best response of chemotherapy. So, if the patient is in CR, hazard ratio is 0.72, and if the patient is stable disease, hazard ratio is 0.84. Although the difference in the response seen in the experimental arm compared to the best supportive care alone. Next slide, please. So, even patients with CR are at risk of rapid progression and consequent lower the median overall survival without the avelumab maintenance. So, it has been seen that if the patients in the avelumab maintenance unstratified hazard ratio is 0.58 in PFS and OS is 0.72. Next slide. So the Asian subgroup represent 21% of the overall population in Javelin Bladder 100, where they have used this first line chemotherapy followed by the maintenance therapy. Next slide. So Asian patients show similar median overall survival benefit as all of the overall population, and 61% of the Asian population are alive after 2 years and more than 10 months of median overall survival benefit in non-avelumab maintenance therapy. And 3 times higher PFS is compared to non-avelumab maintenance. It is 1.9 months versus 5.6 months. So next slide, please. So how long you would like to continue avelumab maintenance? Now it has been seen the median PFS is 26.7 months in patient who are exposed to Vivancio more than 12 months, and median overall survival is not reached. So 20% the patient were exposed to avelumab more than 24 months. 28% if the patients receive exposed to avelumab at least more than 12 months, and 47% patients exposed to avelumab more than 6 months. Next slide. Next slide. So this is a hypothetical patient profile, 1 year, good performance status, creatinine clearance was 38. Which data support the use of avelumab? Next slide. So Javelin Bladder 100, where the long-term OS benefit with avelumab first observed in patient received the first line cis-carbo. So this is our corroborating of that that we have already shown, that long-term safety of avelumab plus best supportive care were similar in the subgroup that received the first line platinum chemotherapy arm. Next slide. So next slide. Next slide. So these are the same. Next slide. Next slide. So this is actually showing if we can use in older patient also. So it has been seen that there is no difference in the OS benefit if we consider that after the first line chemotherapy maintenance avelumab. And it has seen that long-term safety data with avelumab plus best supportive care, the patient with higher BMI generally consistent with the overall population. And we can see hazard ratio is 0.77, and there is a 12.7 months versus 20.8 months median OS data is presenting, and in positive with the avelumab use. Next slide. Next slide. Next slide. So if the patient has the subgroup of the patient who has the lymph nodal positivity or tumor with the low tumor burden, so patient with non-visceral metastasis or patients with a lymph node only metastasis, in both cases it has been seen the hazard ratio in non-visceral metastasis is 0.60 and in lymph nodal only metastasis the hazard ratio is 0.86. In both cases benefit has been seen. Non-visceral metastasis the benefit are more, it is 17% versus 31%. Next slide. Next slide. So it has been seen overall survival benefit also consistent with the population predominantly urothelial cancer and including the subgroups of the histological variants. Like if the histological variants include like urothelial cancer with squamous differentiation or glandular differentiation or variant differentiation, it has been seen that as hazard ratio is 0.74 14 months versus 19 months, and these similar results are reflected in the Avens trial or Euroki trial, that is the French trial and Japanese trial in the real world scenario also. So irrespective of the subgroup of the histological variant, this benefit has been overall survival benefit has been seen in all types of patients. Next slide. Next slide. Yeah, so if the patient, next slide please. So it has been seen if the patient has a diabetes mellitus, so it is a very common in the among the patient. So it has been seen if the patient with diabetes mellitus or without diabetes mellitus, the overall survival benefit does not differ much, and in both cases there is a good hazard ratio 0.60 from with diabetes mellitus patients, and without diabetes mellitus is 0.78. Next slide please. So this is the real world studies where Indian real world studies also shown in favor of the increasing the overall survival rate and the PFS benefit also. Next slide. Next slide. This is the French data actually showing, that is our corroborating with the data that's increasing the median OS benefit and PS benefit in after the first line chemotherapy of maintenance avelumab. Next slide. So long-term safety profile in avelumab that supports the continued treatment with disease until the disease progression, and it has been seen the more than grade 3 side effects are less, and it has been seen mainly the hepatitis or transaminitis and some pancreatitis also, but mostly that real world studies have showed the good safety profile in this avelumab maintenance also. Next slide. So sequence therapy in second line subsequent therapy. So first line Gemcis, then patients with CRP or SD, we have to maintain the avelumab till disease progression and then initiate the second line therapy. Next slide. So in base supportive care arm, most patients received subsequent therapy, received PD1 or PDL-L1 inhibitor also. And it has been seen that in base supportive arm, 73% patient with subsequent treatment receive the PDL1 or PDL1 inhibitors and the other drugs, other targeted therapy right now available. Next slide. So this is the summary of the treatment where the second line treatment rechallenge with the platinum based chemotherapy after the avelumab maintenance if there is a progression, or separate PDL1 expressions inhibitors like pembrolizumab, atezolizumab, nivolumab, or other anti-cancers and targeted therapy, enfortumab vedotin, edrefinitive, etc. Next slide. So when multiple agents are available, how to sequence them to increase the survival. Next slide. So primary platinum therapy followed by avelumab followed by enfortumab vedotin. Here is the maximum overall survival benefit has been seen of 40 plus months. Next slide. So as seen in this Evidence trial that post avelumab, if antibody drug conjugate enfortumab vedotin is used, so overall survival benefit is the most compared to the other sets of sequencing. It is 40 months. Next is the enfortumab vedotin plus pembro, where the survival time after first line therapy is 33 months. Next slide. To summarize, up to 90% of the patients are eligible for maintenance treatment. First line avelumab maintenance leads overall survival almost 30 months, superior overall survival, regardless is the any therapy, chemotherapy regimen used, duration of the therapy, response, and treatment-free interval. And robust real-world data also available to strengthening the results. 80% of the patients are eligible for the second line therapy post avelumab, and unprecedented median overall survival 40 months with sequence of first line avelumab and maintenance followed by second line EV. Next slide. So I'm skipping these slides. Next slide. Next. Due to the shortage of the time. Next slide. Next slide. Next slide. Thank you. So thank you, and I am inviting now Dr. Satish for his session. Dr. Satish, are you available?
So Satish sir is not available, even though his phone is also off.
Oh, okay, his phone is also off. Okay, so can you share the slide, please?
Sure, sir, sure.
Dr. Satish is not reachable, no?
Yes, sir. Dr. Satish is not reachable.
Okay, can you share the slide?
Okay, sir.
Team Horizon, I would request you to display the branding, please, before this session.
Sure, sure.
Yeah, please.
Yeah, the other one. Yes, just a minute. Yeah, it's done. You may please continue. Sorry for the interruption.
Okay, thank you. So can we start?
Yeah, please show the slide, please. Yeah, due to some unavoidable circumstances, Dr. Satish is not available. So I'm just going through his slide. So we
I
will.
think Satish sir joined, I think.
I joined Sanchayan. Hi, sorry.
Arey, I thought what happened? I am
अरे नहीं
also.
मैं OPD just got over sir मैं
Arey.
mobile got discharged.
Okay, please. You
So
are.
I'll thank Dr. Sanchayan Mandal for giving me opportunity to
Please.
speak about recent advances in HER2 positive advanced breast cancer. Next slide. Can you change the slide? Yeah. So gastric cancer is the fifth most common frequently diagnosed cancer and fifth leading cause of cancer-related deaths worldwide. Now, as we know, the incidence and mortality are expected to rise given the lifestyle which we are living and the obesity which has been associated with the major risk factor with this cancer. And the mortality, again, it has increased in India and Asia because of the lifestyle changes and the new pattern of dietary habits which we have been following. Next slide. Now, the prognosis of gastric cancer, which we all know, is poor and varies by the stage of the disease. So here we hardly get in our place in India the localized cancer. Generally, what we get is a regionally advanced and distant metastatic disease. And the 5-year survival of gastric cancers is 25% globally. And given the scenario in our country, it is much poorer. So the 5-year survival, even in the United States, it's 34% for regionally advanced disease and 74% for localized disease. And a very minimal opportunity proportion for our patients, we diagnose them in localized disease. Generally, they are in locally advanced or metastatic disease. Next slide. So now, generally, the management overview. So in early stage gastric cancer or gastroesophageal cancer, either stage 0 and 1, there is where there is no metastasis, so there is a curative intent and endoscopic resection or surgery is done. However, when the patient is either in stage 2, either the patient is stage 2, 3, or potentially 4A, then we give a NACT, either FLOT or FLOT plus immunotherapy. When they're in metastatic gastric cancer or GE junction, then either we go with chemotherapy, and based on the our NGS report, if there is a target available, or immunotherapy plus trastuzumab based therapy if they are HER2 positive. Next slide. Now, HER2 is an important biomarker. We have seen in breast cancer how it has changed the scenario of HER2-driven breast cancer. In here in around gastric cancer, around 12 to 20% cases where the HER2 is amplified or overexpressed. While in GE junction, it is much more, around 30 to 40% what we get in our private practice. Again, when we go with pathological type, intestinal type of gastric cancer will have 30%, and diffuse type of gastric cancer has 5% of HER2 overexpression. Next slide. So HER2 positive disease, adenocarcinoma, the amplification, HER2 positive adenocarcinoma characterized by amplification of HER2 gene that results in overexpression of HER2 receptor. And there is intratumor heterogeneity of HER2 expression of around 50% in 50% of the cases. Next slide. So this we know the testing for the NCCN guidelines. If HER2 3 plus is generally considered positive, while if we have HER2 2 plus, we have to confirm it by FISH. But when it is 1 or 2, if the FISH is negative in for 2 plus, then we generally what we do is they are not considered now negative, but they are considered as HER2 low positive. Next slide. So now going with current standard of treatment, like in first line treatment, there is either 5-FU based therapy plus platinum, which is generally either Capox or Folfox, combined with trastuzumab or pembrolizumab or nivolumab based on the CPS score. Now, second line therapy, if it is either generally if there is a HER2 negative disease, either it's ramucirumab plus paclitaxel, or it is trastuzumab deruxtecan. But yes, the things are we have used deruxtecan. And next slide. And in third line, the options are quite less. Yes. And next slide. So this TOGA has shown there is improved OS where the trastuzumab was used with a chemotherapy, and that showed there is a PFS benefit and OS benefit. This showed as a path that even the trastuzumab based therapy are going to work in this cancers also, in stomach cancer also. Next slide. So Keynote 8.1 phase 3 study showed that pembrolizumab so it showed that pembrolizumab with trastuzumab, like we have seen that in patient where the HER2 positive disease is there in CPS is good, where we can give trastu plus pembrolizumab or immunotherapy. And with this study as primary endpoint point as PFS and OS, this has showed a benefit, a positive benefit of adding immunotherapy with trastuzumab. Next slide. Next slide. So when first line anti-HER2 treatment that didn't provide a significant improvement in HER2 positive disease was, and like we have seen in breast, sorry, that combination of trans2 per2 didn't work much well at is used to be in breast cancer, and what we have seen with generic pertuzumab didn't work much well. Same thing with combination of lapatinib didn't work well. So not much of benefit. Next slide. So what is the problem? So when we are giving HER2 based therapy, if the patient is HER2 positive, so here what is happening? There is a down regulation of HER2 receptor. First thing, and second thing, the HER2, there is a resistance which is happening because of this thing. So patient with gastric cancer, suppose if they are they don't have option in second line. Suppose we have given trastuzumab, and now the trastuzumab doesn't work much well. So what are the other options? So the options are quite less. So now the Dristucan, let's see if the Dristucan can this patients. Next slide. So the rainbow study, it did show it is a double-blind randomized phase 3 trial which showed that ramucirumab plus paclitaxel plus placebo versus placebo plus paclitaxel had a significant OS benefit. Next slide. So in rainbow study, ramucirumab in combination with paclitaxel has shown OS benefit, which is we all know that patient who progressed on the primary line is the ramucirumab is the next best line. We have also seen in some of the patients who have improved, who has progressed on some of my patients who has progressed on immunotherapy. They have also done good with ramucirumab. Next slide. So now anti-HER2 treatments that no, this one we have already covered here. Next slide. So Destiny.
Sorry for interrupt. Kindly conclude.
Also, we can conclude now. So we can go to directly Destiny 04. Hello, can you change the slides? So, next slide. Next slide. So this Destiny 04 restaurant, this Destiny 04 showed us. Next slide. So next slide. Next slide. Next slide. Next slide. So this Destiny 02 design with when they used Destocan with 6.4 milligram per kg, it showed a good overall response rate. Next slide. Next slide. Next slide. So here we have seen that they had a good, there was a overall response rate was better with Destiny 04. Next slide. Next slide. So we know that probably this was the last slide where we have seen that Destrucane is a well tolerable ADC. The side effects of ILD has what we have seen when we are using in gastric cancer is much less, and also with evident of time we have also become better to know how to handle this ILD related side effects. So I would like to thank Sanjay and Mandal for giving me this chance and the organizers. Thank you.
Thank you, Dr. Satish, for your wonderful presentation. Really, today it is a good evening and it is a great learning for all of us. So we have discussed many topics starting from the panel discussion and epidemiology and the topic-based presentation. We learned a lot. So thank you. Good night, everybody. And thanks again for the faculty for their time in this evening out of their busy schedule. And we will again do such of meetings in future. Thank you, everybody, and good night.
Thank you, sir. Thank you so much. Thank you, everyone, for joining. Thank you, Vishal, and thank you, Daud. And thanks to technical support. Good night, everyone.
Good night then.
Technical team close the meeting.